Hello. Hello, everyone. Please kindly scan the pre-test and let's see where your knowledge base is before we even start the program. We are very sorry for the start of this presentation of this program. We'll start shortly, probably in the next 5 minutes. So take that next 5 minutes to answer the pre-test. There will also be a post-test. So let's listen attentively and let's participate in the program. Are we having any difficulties scanning it? Okay. Hello, are we done with the pre-test? Oh, it's a short question and answer. Are we done with the pretest? Was it difficult? So pretest 100, right? Then there'll be no need for the post test. Melvin, they said it was so easy. All right. I apologize again for the late start of the program. This is the second oncology summit, and that is being held in Cape Coast. We've had great success with the first one, so we had to repeat for this year as well. The oncology team partners GMA, and the reason is that GMA this year, Central Region is the focus. So everything that is revolving around the medical association is all fixated in Cape Coast. So in partnering with Cape Coast or Central Regional Division, we are able to get some CPD accreditation for this program. So those who have not registered, please do so and register so that you can be credited with a CPD point. And members who also want to join, they can join online. There will be a YouTube recording which we can share so that if you want to still update your knowledge in terms of the MDT program, you would always do that. We have a lot of sponsors with us. We have Pfizer collaborating with us, and also our nice setup is by a pharmacy company. So they will introduce themselves later on in the program. This program is key in the era of personalized cancer care and the era of precision oncology. Multidisciplinary team discussions in oncology is important. So the theme for this program is very appropriate, and we have the team leader to give us a few remarks before we start. Anyway, so we have Dr. Melvin Ajimai to give us some few remarks before we start the presentations. My name is Dr. Emmanuel Sofori, and I am the chair of GMA Central Division, and I'll be hosting the 67th annual Congress here. So please, this is just a prelude to it. We have snack at the back there. We'll go for a snack break very soon. But we'll take a few of the presentations before we go for the snack break. So let's welcome Melvin, Dr. Melvin Ajimai, to the stage. Well, let's do it for him. Let's do it better for him.
Hello, good morning. So, over the past 5 years, oncology services have been introduced to Cape Coast Teaching Hospital, and I think they've been some success. But everything we need to audit, we need to improve, we need to know how best we will be able to optimize our care for our patients. So that's why there'll be need for us to be having these seminars, just to refresh our minds and the new ones to know what exactly is coming on board. So for this second oncology summit, we chose the team enhancing cancer care through multidisciplinary team, improving patient outcome and care delivery, because we know that MDT is very key for patient outcomes or improve survival outcomes, which we'll be showing in our subsequent presentation. So as you are here, you are warmly welcome. And so don't be discouraged about the numbers here so far. We are hoping that maybe it will get better, but so that we don't waste time, we will go ahead and start today's program. Okay, so I will start with my presentation on multidisciplinary concept in cancer management. What exactly is MDT? Because most of the time we normally hear, let's go to MDT, we are going for MDT meeting. What does it entail? That's what I'll be focusing on this morning. So this will be our outline. We'll have a brief introduction. We'll go through what MDT is, the benefits of MDT approach in cancer care, then current challenges we have with MDT, and real-world impact of MDT, then we will conclude. So for cancer patient journey, this is how it looks like. most often a patient have a symptom, report to a nurse or a doctor. It can be a primary or a specialist. The doctor will evaluate and go ahead and diagnose the patient. In this case, since we are talking about cancer, depending on where exactly is the diagnosis of cancer, and that can be done by the nurse, the oncologist, the pathologist, or the radiologist. Then the treatment decision is made, and based on that, the nurse, oncologist, or the surgeon will administer the treatment. During the treatment, patient is being monitored by the nurse, oncologist, and the radiologist. And when the patient is cleared of the cancer, the patient survives.
Recording in
If
progress.
there is disease progression, the patient will go through another sort of treatment. So if you look at the cancer journey, it looks like it's pretty simple and easy. It doesn't really entail much. Once you know where you stand, you can easily coordinate and manage your patients, which is quite acceptable. But the truth of the matter is, this is actually how cancer pathway for most patients, of every patient, looks like. It's not really straightforward as such. There are a lot of gaps. There are a lot of solutions that you may have. There are a lot of referral pathways. There are a lot of obstacles that comes into the way for the patient. So you need to find ways and means that you'll be able to coordinate the care so that the patient will have a seamless care without any issues. So that's why mostly multidisciplinary team approach tends to be quite essential. Even if you take out the cancer aspect of things, patients also have comorbidities. So throughout the process of care, patient may need to see the cardiologist, probably will need supportive care. If the patient is a diabetic, might have to see the endocrinologist. Geriatrics, if you're managing an elderly patient, is different from managing a younger patient. If the patient has some maybe pain or probably peculiar things that have to be managed by the palliative care team, you need to bring them in, the nephrologist, the nutritionist. So there are a lot of people that will come into the pathway that will be involved in the patient care. How do you coordinate them? How do you bring them into play? That's what MDT basically looks at. So what is MDT? Or with time you will come and see that mostly we talk about MDT. When we talk about MDT, it means a multidisciplinary team. So we are talking about a coordination of individuals. Coordination of individuals or team of different specialties applying their expertise to solve patients' problems. So you have to coordinate. You need someone who will coordinate. So you need a good leadership to help with the coordination. It can be an individual or teams because, like, let's say we have the surgical team. You can be working with a lot of them, so it makes up a team. But maybe probably the psychologist may be one person. So an individual, the person can come on board. The nutritionist can come on board. That person's an individual. A majority of the time when you talk about the terminology, you hear multidisciplinary, you hear about interdisciplinary, you have cross-disciplinary or transdisciplinary, and we normally use them together or interchangeably, but sometimes they are two different things. Each of them tend to be unique on its own. So to help us with the definition, one of the things that sometimes you have is what we call monodisciplinary, when one person makes the diagnosis and all the decision and treat the patient throughout the whole period of time. So there have been instances where you probably have come across a patient probably with breast lump, went to see a doctor. The doctor went ahead and do that wide local excision or mastectomy without sending sample to histopathology. That's what is a monodisciplinary takes. Sometimes they will even send it to pathology, but whether the patient will need chemo or may not need chemo or will need hormonal therapy, they don't care. So every patient will receive chemotherapy. If the patient complete treatment, whether the patient did immunohistochemistry or not, they'll put the patient on a hormonal therapy, which is a common thing that you normally see in an environment. And when we talk about multidisciplinary, it's different from multidisciplinary team. When you talk about multidisciplinary, you may have different disciplines that are solving the patient problem, but they don't interact. So there'll be instances maybe where the patient presents to a doctor, whether a GP or a surgeon, they do a biopsy. The person goes ahead to go and do a mastectomy or wide local excision. Maybe there may be need for the patient to do chest X-ray or abdominal ultrasound. On that abdominal ultrasound, there might be metastasis, but the surgeon doesn't really think about it. So the patient has a lump, I'm just going to take it out. There's that no collaboration within the two groups. So each of them know that, okay, the patient has a problem that we need to solve, but they are doing it independently. So that's when, if you are talking about multidisciplinary, it tends to imply. But when you are talking about multidisciplinary team, which is the third thing, that one they try to coordinate. And that's what is being practiced to a certain extent at Cape Coast Teaching Hospital. So in that case, if a patient comes in, maybe from the time the diagnosis is being made, the patient has to see the surgeon, a biopsy is requested. Then the surgeon go ahead and do the biopsy. The surgeon may probably call the pathologist to follow up on the biopsy, find out whether when the immunohistochemistry will be ready. Maybe the chest X-ray or a CT scan is done. If the radiologists have any information, they can easily call the surgeon for those information. So there's always constant interaction with them. And with the multidisciplinary team, what the core of it is when they meet together. That's when you have the multidisciplinary team meeting on the MDT meeting. So during that period of time, they are coming to sit down to make a decision for that particular patient. So that tends to be an important aspect of that. When we have what we call the transdisciplinary team, in which decisions are made, it's a little bit like the multidisciplinary team, but in this case, it's mostly used in advanced stages or maybe in research or peculiar instances where they need to develop a new framework or concept for a patient. So all these that we are doing for multidisciplinary, they don't just follow the routine, but probably will go ahead to do more than that. So why is MDT essential in cancer care? MDT is essential in cancer care because it's now the gold standard of care. Because there's no cancer patient in a proper setting who doesn't go through MDT. Every cancer patient is supposed to be discussed at MDT. And that's one thing to a certain extent. Like I'll probably say Cape Coast Teaching Hospital, we are doing much better. Because if you come to Kolubu, not all patients go through MDT. Some will have their treatments initiated before or only counts as and when. But at least for here, we are trying to streamline it so that every patient will come through MDT for the decision to be made. And the most important thing of the MDT is decisions are made based on evidence that's available. We are not making decisions because, okay, that's how I was taught some 7 years ago or some 10 years ago. We are catching up with the new things that are ongoing. So you can then decide that, oh, based on A, B, C, D, that's the best decision for each individual. And you are making decisions based on that particular person. So it's not a blanket thing. You don't make decisions that, okay, all breast cancer, this is how you manage them. Or maybe colorectal cancer, this is how you manage them. You take the person individually and you manage them. And one thing about multidisciplinary team meeting is that it consider the patient's physical, emotional, and psychosocial needs. Because each patient comes with their own complaints or their own worries. So with MDT, you are supposed to identify the major problems, not just about their disease, but what are they facing, what psychological impact is having, or what toll is having on them, so that you bring them on board. So that's why you may probably have the psychologist, the nutritionist, all being part of MDT. Because once you identify any issue, you have to get someone who will be able to adequately handle it. So when it comes to multidisciplinary approach, is it the same as MDT meeting? And the answer is no. Because MDT meeting is, even though it is integrated in a multidisciplinary approach to care, cancer care, it's just a part of it. MDT meeting is just one aspect where you sit down and make the decision. But mostly when you talk about multidisciplinary approach, it starts before MDT meeting and it continues after MDT meeting. Because before, you have to interact with each other to be able to come up with a diagnosis. And once you have the meeting, you discuss or review the patient document and make a decision. And once that decision has been made, you have to implement it. So the MDT approach goes in that direction. So mostly during the MDT meeting, what you do here, you are just reviewing the patient information, what have been presented to you so far, your history, your examination, your the findings that you had from your images. You make recommendations and also serve as a peer review in real life time. Because during MDT, you can critique each other, probably know how we can improve or get things done better. Because once you are critiquing each other, it's just like maybe you're going to publish a study elsewhere. Once it gets there, the same critique that you probably have received, you have received it earlier, so it helps to make your work quite better. And in so doing, it helps you improve your confidence in whatever you do. When you talk about MDT approach, mostly it's made up of three main things: the team input, the team process, and the team output. The team input is one. The major thing is attendance to the patients, attendance to meeting, and being consistent with meeting. The other thing is the expertise that you are bringing on board, because with MDT, it's mostly about, the ideal thing is for you to get a specialist, everything being on board. It's not really, you may have the residents, you may have the medical students, you may have other people, but the main thing is the specialist. Because when decisions are being made, the one who can actually defend the decision is the specialist. So it's not always good for maybe, okay, you're the resident to, okay, MO or resident, go and present this case and bring us the feedback. It's not a form of consultation. It's a meeting. We are supposed to deliberate. We are supposed to share ideas. So the expertise are quite good when it's required for MDT, the input. And you all need a lot of information. So sometimes maybe if you come for MDT and you are not really prepared, or you don't know much about the case, it's going to drag the meeting, or there will be a lot of back and forth. So they always, even if you don't know about, it's not your case, it's best you review the case very well, go through, know where the gaps are, then fill it before you come for MDT meeting, because that's those things that will help us make a decision. The major thing about MDT meeting is at that point in time, you want to make a decision. So if you are going to go back and come with more information for that decision to be made, it's not really going to help. So we need to improve on that. And the other thing for the input is equipment. For you to make meaningful decision means that you have to really evaluate the patient well. So you need your good imaging, you need a good history, you need sometimes elsewhere, even during MDTs, maybe like let's say examine, either a laryngoscopy or nasolaryngoscopy has to be done for everybody to see whatever they are discussing. So that's one thing about the input. And when it comes to the team process, you need an expert to review, and that's as the expertise. You need an expert to review most of the information that have been provided. You need to work as a team, because you are making the decision based on the patient, but not based on individual or what your preference is. So you have to put the patient at the center of everything and make the decision as a team. And you should have an open discussion. You shouldn't fear that, okay, maybe probably this particular person is around, so I don't want to talk, or I don't want to step on or overstep my boundaries. We are there for the patient. So if you have anything that's bothering you, you should be ready to speak to it. You shouldn't accept it because the oncologist says that, so this is the best treatment plan. You should defend whatever you have in mind. And we need good leadership for doing the team process, and the good leadership can be the interdisciplinary leadership and intradisciplinary leadership. The interdisciplinary leadership, someone who will ensure that always the MDT runs, make sure that everything goes on. You need good leadership for that. And within the individual teams, you need your own leadership. So what are your challenges? Maybe probably the time that you are supposed to have MDT, maybe you have other activities done. Can you rather maybe delegate some people to come for that particular meeting? Maybe have a schedule. This week, you will be going for MDT. The following time, this person is going for MDT. Or have someone who always ensure that at least cases are presented, or cases that come through the department get to be discussed at MDT. So the leadership role is also very important. And when it comes to the team outputs, it helps is the decision making. Once you've made up the decision, you need to implement it. And the most important thing about MDT is the documentation, because majority of the time you will find that maybe probably they'll write, okay, to discuss at MDT. The patient is discussed after MDT, but there's no documentation what exactly was discussed or what was the plan at MDT. This always affects things, because if you don't know the plan, it means that you didn't discuss indirectly. So you always have to ensure that once you've discussed any patient as MDT, you go back and update the patient notes so that it makes it quite easier for everybody to follow. And when you have documenting is not just about the plan, because sometimes peculiar patients may have peculiar needs, and there will be a little bit of back and forth in regards to why the decision was made in that way. You are supposed to document all of them just to help anyone who picked that document to know that, okay, decisions were made based on A, B, C, D. And during the output too, there should be a good communication between the team or the doctor and the patient, or even between each other. So with a good communication between each other, that's why you need a navigator to try and navigate or probably see to it that someone who coordinates the MDT meeting, so that when there is any communication between in any of the discipline, that can easily be done. But there also have to be communication between the doctor who presented the patient and the patient, because sometimes what we normally say is patient have been discussed at MDT, afterwards, okay, you are being referred to oncology, or probably you are being referred to Kolebu, you are being referred to go and do this. Actually, after the MDT, you are supposed to sit the patient down. There's the discussion that we had. There's the plan that because patient tends to have confidence in people at each point in time. If we are going to try and refer them to a particular unit, they don't know whoever they are going to meet there. But once you talk to them that these are the plans, or this is the way forward, it gives them a kind of reassurance, and that tends to improve adherence. And the other thing about the output is you may have data that you can easily carry out research. Okay, so what's the composition of MDT? MDT is mostly, we tend to have core team members and non-core team members. That does not mean that so far as you are non-core team members, you are not important. What it means that there are people who are always involved in cancer care. You always need an oncologist, a radiologist to do your imaging, a surgeon to do your biopsy and also to do your surgery, the pathologist to review the pathology, the nurse to navigate things or coordinate. So you have people who are always in the center of things. That makes them the core team members. But I can also have the non-core team members, which can be the psychologists, because if you have a patient with a lot of psychological issues, sometimes they are not going to adhere to your treatment. So that means the psychologist is very important. If you have a patient who has lost a lot of weight and you don't have a nutritionist, then that means all that you are planning, you cannot implement it. So everybody tends to be important. So we can have the palliative care physician, the nuclear medicine physician. You can also have the physician in training or medical student and geneticists. So majority of the time, the MDT, the core members, everybody bring their expertise on board. So with the oncologists will probably talk more about the chemotherapy, radiotherapy, immunotherapy. The surgeon will have more information about the type of surgery to be done. The pathologist will review the histopathology and the molecular profiling and tumor analysis. Radiologists will do the imaging, and the nurse oncologist will give medication, administer, and also manage patient symptoms as and when. There will be a topic on nervous navigation, so I'll just worry about the nervous navigator tends to be quite important in MDT because majority of the time, whatever we say is more of you are saying brofo. So somebody have to speak the truth to the patient or the fancy to the patient. So that's one thing about the nurse navigator. Imagine if your patient comes to us as a doctor, within that short period of time, you don't really have a lot of time to discuss a lot of social things with the patient or even what is bothering them. Sometimes it's not because the patient cannot afford the treatment or probably maybe he doesn't want to continue with the treatment. The patient is lost. You think that Cape Coast Teaching Hospital is a small place, or within 5 minutes you can walk around Cape Coast Teaching Hospital. But Cape Coast Teaching Hospital is their Kolebu. So when you come and tell them, go and do full blood counts, go and do BN creatinine, go and do X-ray, the person is just lost. Where am I going to start from? So with all these things in mind, the patient navigator helps the patient to at least orient well so that they will know where to start from, how to go about with their treatment, and they don't get lost in the system. So how do you become a good MDT member? For you to be a good MDT member, you always have to come prepared. And this, I think something we don't normally do, but with time we are going to see that we implement it. Because coming prepared means that most of the time on our platform, we normally will say, how many cases do you have? So they'll update us with the number of cases. But going forward, we have to look at you actually updating us with the cases you want to present the following day or that particular week. Everybody should be able to go through. The radiologist, if they have issues, they can probably will be able to solve it. If the pathology have something to be done, they will probably do that. Because sometimes, ideally, for a good MDT, like if you do a CT scan, the radiologist is supposed to review it before they come for a meeting. And once you have updated us with a list of cases you are going to present, it make it quite easier for them to. Sometimes you may come, maybe the oncologist, if I've read about it earlier, it will help me, also come up to know that, maybe this is the best treatment plan or this best for the patient. So all these things are quite important. So we always have to come prepared. And the other thing is we need to communicate well. We are supposed to make our stance and ensure that, okay, we communicate well to each other, because it's not a form of consultation, or it's not a platform for us to show who knows much, or who knows best. But if the thing of our MDT is we are just collaborating among each other, so everybody is bringing their mindsets. And at the end of the day, decision or whatever is going to be said, it's not going to be said that, okay, Dr. Ajuman said this, or probably Dr. Nyantechi said this. It's going to be MDT. So if there's any legal issues, everybody at MDT is going to be held responsible for. So don't feel shy maybe bringing out any contribution that may be necessary. And you should have to at least collaborate with each other. You probably have to know where to start, so that everything will be able to come out well. And the patient should be your main focus. The decision about MDT is not what I want, but what the patient's choice is also quite important. And that is not saying that if the patient's choice, you think that it's not that good, you then find a ways and means to probably talk to the patient. Because there have been instances where probably patient may, or an early breast disease, the patient will say that, okay, I want mastectomy because I don't want radiotherapy. Or maybe I want mastectomy because of, or maybe I fear that the disease will come back. Maybe the surgeon will speak to the person. But when the patient comes to another, maybe you let another, like an oncologist speak to the person may not understand that, so this is the main reason, okay, conserving the breast is it's a good option. It's not that bad how I think it was. So always we should stay patient focused, but we should know when to at least bring other people on board just to help us make a good decision. And it should be reliable, because if you are coming to make decision and anytime your decision, people have issue with it, or probably implement your decision, there are always issues. People are not going to trust your decision making. So as MDT, we should be very reliable. Every decision that goes out to be something that people may, or any person who takes our documents will know that, okay, it's something of international standard. And one thing about MDT, for you to be able to appreciate MDT and be more effective, you always have to keep learning. Because sometimes during MDT, I learn, but you also, if you are going to MDT, sometimes depending on the type of case, that's why it's always best you prepare. Depending on the type of case that have been presented, sometimes you even have to go and read. And when you go and read, you know that, okay, there are new things coming. That's how you always catch up, because always you may not be able to follow up or catch up on everything that's coming in and day out. And oncology is moving very fast, and the research in oncology is also rapidly evolving. So you always have to make sure that you catch up with. And you always have to maintain confidence and professionalism. You have to respect each other. If you are presenting a case, you should be confident in whatever you are presenting, so that people will gain your respect. So what are the benefits of MDT? MDT has benefits for both the patient and both the healthcare givers. The benefit is not just because of the patient, but to the healthcare givers, it's also help us. So the one is to reduce variation in the access of treatment, because if a patient is seen or is the case at MDT, majority of the time, the way you're going to treat such team or such cases are always the same, compared to when the patient is not discussed at MDT. Maybe the patient comes to me, I will think that, okay, let's give neoadjuvant chemotherapy. And it goes to another person. The person will say, oh, go and do upfront mastectomy. Another person will say, oh, no, do wide local excision. So different people will have different things. But once you have an MDT, it makes it easier for you to streamline things. The other thing is you are going to make personalized decisions. So everything is going to be based on that particular decision, and you're going to use evidence to help with your treatment. It tends to make a decision faster, because from the onset you have a plan. And once you have a plan, everybody knows when they are coming in. Everybody knows when they have to be involved. So in so doing, it tends to reduce the waiting time for most of your patients. And there's better coordination and continuity of care. So because you know when exactly you are coming in, there's no break within treatment. Because first, before oncology services started in Cape, patients may probably will have chemo, maybe after a number of months go and have surgery. After the surgery, they are now going to think about how to get money for radiotherapy. And some of them will come for radiotherapy after a year. by that time the benefits will be little or no. So, or even by the time they report for radiotherapy, there will be metastasis. So it helps to have a continuity of care. And it improves communication between healthcare professionalism and what I've already said, and it gives high patient satisfaction and confidence in their care, because if they know that, okay, everybody goes through MDT, the treatment is basically the same, it let them have confidence in whatever they are doing. But if they come and A is being treated with different medication, B is being treated with different medication, it tends not to improve their confidence. And the major thing about MDT is improved survival outcomes. So it's not just the fact that MDT is just there to coordinate or make things well streamlined, but actually can improve survival outcomes, which I will show you the real time experience. But to the health worker, what's the benefit of MDT? It helps share decision making, because one person doesn't make all the decisions. So it's sometimes easier for you to go ahead with your decision. Well, I think at our last MDT meeting, there was a case where I think the maxillofacial presented a patient with adenocarcinoma of the oral cavity. It's quite rare to have adenocarcinoma in the oral cavity. But when they were presenting it, there were swellings at the upper part of the body, and there was something in the abdomen. When they did CA125, CA19, it was highly elevated. So in those days, somebody can then say that, okay, maybe I think it's rather maybe a pancreatic lesion that's rather metastasized to the oral cavity or something like that. So it makes it easier for you. Otherwise, somebody will see that patient and say, so adenocarcinoma of the oral cavities is amendable to surgery, so you just go ahead and do your surgery. And later, the patient will have other complications. So with the health caregiver, it's also here. It improves communication across specialties, which I've already made discuss, professional development and learning, because doing MDT, it's not just about sharing your knowledge. Actually, doing MDT, sometimes you actually learn a lot, because there's a lot of things that I've learned. I'm an oncologist, mostly I do breast, I do head and neck, and I do GU with a little bit of pediatrics. But sometimes gynae, it's been a long time since I did gynae oncology. But sometimes during their MDT, they will probably say something which I've learned maybe a long time ago, the thing have changed. And to you, it will help you, because if you are going to do locum somewhere and you get a gynae case, it helps you out. So, these things are things that you tend to learn. And for maybe the residents, how patients is managed in Cape Coast, it should be a standard of care. It's not really maybe what your senior taught you. Because if you are going to, for exams are going to quiz you based on the standard of care. So if you go through MDT, because it's given a standard of care or more evidence-based approach, you always keep updated with how things are going. And it's more efficient use of resources, because you can easily streamline things, know when to at least use which resources or bring people into play, so that you don't waste a lot of time. Because sometimes maybe patient may be roaming from one place to another just because there's no coordinated care. But if you're doing MDT, you can then decide that, okay, probably patient has hypertension, should you go to the primary caregiver? No. Because maybe you are going to give chemo, you need a cardiologist. Let the cardiologist manage ABC, so that it make it quite easier for the patient. And there's a better understanding of the whole patient for the health workers. And as I mentioned, it also acts as a peer review in real time, so you can actually critique each other's work and see how best you improve on that. So what are the challenges we face with MDT currently? Now the numbers are increasing, and therefore the number of cases we are discussing are also increasing. So they have to find ways and means that we'll be able to adapt and cope with the increasing numbers. The other thing is there are a lot of complicated cases that we are now seeing, because some patients are previously mismanaged before they are referred to you. So sometimes maybe, assuming let's say a breast case, the person is seen, was given AC TAC. Along the line, when the neutrophil levels are low, they will give the person capecitabine. Along the line, without any IAC, the patient is being given hormonal therapy, and now patient comes to you, patient has progressed or has metastatic disease. All the medication that you probably have to give has been insufficiently being given, so the probability of developing resistance tends to be high, so it makes the decision making a little bit difficult. Also, the more we get new agents or new treatment protocols, makes MDT a little bit complicated. because you have to find ways, and maybe now the medicine is moving to personalized medicine. So you have to find ways and means of at least personalizing it to the patient. So even though the medications or the treatment options are coming to help, it makes your decision making a lot more trickier. And sometimes, because in our environment, some of these new regimen needs a lot of molecular studies. But unfortunately, it comes at a cost, or probably it's quite expensive for most patients. So even though the options may be there, it will be, it's also add-on, complicates the decision making. And other thing I mentioned is the inconsistency or incomplete documentation we all normally face. So from henceforth, we have to make sure that at least every patient that is discussed at MDT is updated on the LIMS, so that whoever follows up or who is going to continue care can easily know what to do next. And another challenge we normally have is mostly, as we look at the inputs, we need expertise and the expertise review. So if you don't have the expertise, and mostly all residents or MOs are coming, sometimes they don't really have much information about how to manage the patient. So it becomes a big challenge. So the patient may probably have to go, and maybe they'll have to go, and maybe later on the consultant will call you. So in so doing, you are not really having the typical, there's delay in decision making, because you are not getting all the information at a go. But if there's a specialist around, the specialists know more about the case or have more idea about how the patient should be managed. So in so doing, it makes it quite easier for us to make a meaningful decision. So what are the real world impact of MDT? So there have been a lot of studies that have actually looked at MDT, patients that have gone through MDT and patients that have not gone through MDT. One of these study was by Chia et al. That looked at the effect of multidisciplinary team care on the risk of recurrence in breast cancer patients. It was a national match cohort study that was carried out in Taiwan. And they noticed that for patients who went through MDT, that's the dotted line, and patients who did not go through the MDT, that's the solid line. Patients who did not go through MDT tend to have a higher risk of recurrence, because there's recurrence rate. So whilst most patients who had MDT are about 17% are recurring, patients who had no MDT, as high as 20% of them will recur within the first 2 years. So this actually even show how MDT, because you are cutting down on time, you are having a streamlined or effective management, and this tends to improve on survival. Likewise, there's another study by Rosanda that look at pre-operative multidisciplinary team assessment. Assessment is associated with improved survival in patients with locoregional advanced colorectal cancer, a nationwide cohort study in 3,157 patients. So they looked at patients who had went through MDT, that's this line, and patients who did not go through MDT, which is this line. And they noted that most of them, survival probability tends to be very high so at like 2 years, if you draw a line to this place, you know that those who survive for a patient who didn't go through MDT was a little bit above 60. But those who went through MDT was almost around 80. So that means sending a patient through MDT, it's not just about making it convenient for each other or making the workload easier, but actually it's improved on survival outcomes. So in conclusion, I just want us to know that MDT is a gold standard of care for every patient. So for every patient, they have to go through MDT, because all the expertise will be there to help solve the patient's problem. And even though there is a rising increase in the number of cases and the complexity of cases, we need to find ways and means to be able to meet up with these demands. And to strengthen the MDT concept means that we have to coordinate, have strong leadership, more consistent care, and improve outcome for patients. Thank you.
Thank you, Melvin, for that wonderful presentation. I've learned a lot. Most of us were doing MDT in a different way. All right, thank you. So he told us that there are some core members of the team. So we'll invite one of the core members, which is the radiology team. We have Dr. Millicent Inti. You know, most often we get plain films and a lot of reports, but we don't really see what the report is saying with the plain films. So now that she's here, she will come and tell us some innovations that is going to help us understand what they are telling us on the films. So let's welcome Dr. Millicent Intiankra.
Good morning, everyone. So I think I've already been introduced. I'm Dr. Intin, a radiologist at CCTH. So today I'll be talking on innovations in imaging, optimizing diagnosis and treatment. Okay. So the introduction, we'll just give a brief history on the progress in radiology, the imaging modalities available in Ghana, advanced imaging techniques, the role of the radiologist. Then just discuss 2 cases. Then we'll bring the presentation to a close. So from the 19th century, a lot of innovations have been made in imaging. Initially, physicians need to just rely on X-ray to make a diagnosis. But over the years, we have the development or the advent of ultrasound machines. Then we have the CT scan, we have different generations, and each generation seeks to overcome the problems the previous generation had. Until we had the helical CT and multi-slide CT scan being done or invented in 1980. But currently, focus is being placed on intervention and gene therapy as a way to stop or offset the development of cancers. So the role of radiologists in multidisciplinary team for screening of cancers, diagnosis and staging, treatment and monitoring, and for follow-up. So the screening, especially for breast cancers, it's advised that for every woman aged 40 years and above, yearly you have a mammogram done. But what I've noticed is that people tend to be scared of the mammography, so they tend to just go and do an ultrasound. But that's not the advice one. The advice one is to do a mammogram yearly after 40 years of age. But if you are someone with a family history of breast cancer, and you mostly do the mammogram before the youngest person in your family got breast cancer. If the youngest person who had breast cancer was 30 years old, it means that you must start your screening some years before 30 years. Then we have the treatment and the diagnosis is just like you need the imaging to make impression about the condition that the patient is having. So for example, everybody can have a lump, but not all lumps are cancerous. Some lumps are benign, not malignant. So the ones that are benign may not need the oncologist to manage. It's the malignant ones that we need oncologists to manage. Then we come to treatment in that there are imaging techniques that can help to directly inject the chemotherapeutic agent into the cancer, so that in a way you can shrink down the cancer. Then it comes to follow-up. Follow-up is after treatment, the surgeon has done this surgery, the oncologists have given the chemotherapy. They want to compare the previous imaging to current imaging to see whether there's been improvements. In the case where there were meds, have the meds cleared? In cases where they are giving you a different therapy, as the size of the tumor shrunk before the patient, the surgeon can also go and do the surgery. So this is very important, and I think that's what sometimes we feel. Because when we give patients that maybe follow up in 3 months' time, some patients will go and come back when they are dying in 5 years' time or even 13 years' time. So I think, as Melvin said, the previous presenter, it's good that the team we talk or communicate with the patients so that they will know the importance of these things, so that they will seek help faster. So what are the imaging modalities available in Ghana? We have ultrasound, plain radiography, that's X-ray, fluoroscopy, mammography, CT, MRI, then some radionuclide studies, like the bone scan. Then we have interventions. Even though maybe it's broadly said that we are doing ultrasound, the current innovations in ultrasound are not basically done by every department or every facility that has the ultrasound machine, because some of these innovations need algorithms, and these algorithms have to be implanted into the ultrasound machine. It all comes with a cost. So people don't really want to take care of that. So we have the ultrasound perform just the normal grayscale and color scale and cannot function as an elastography, which is needed. I'll talk about that one later. The modalities that are essential to cancer management but are not available in Ghana are PET scan, then tomography, but apparently Quest Diagnosis Center in Accra has the breast tomography, that's the breast tomosynthesis. So what are the advanced ultrasound techniques? We have elastography. And this elastography is basically you want to check the firmness or softness of a lamp. Just in clinical practice, when you see a lamp, you check whether this lamp is likely to be cystic or it's likely to be solid, and whether the firmness is very high, because it's assumed that very firm lesions are cancerous. So what the elastography does is we have two types. We have the static elastography and we have the shear wave elastography. And I'm sure you've all heard of ultrasound probe, and you've all seen it before, and that's what we call the transducer. So when we say static elastography, it means that you, the person scanning, will apply pressure on the lamp with the transducer. And as you apply pressure, you want to know how the tissue within the lamp are displaced. So most of the time, to see that you can just check the size of the lamp before and during the compression. If the size of the lamp reduces, it means that this lamp is actually a bit soft. It's not that firm. Because firm or cancerous masses, when you apply pressure, there may not be any distortion in the size of the lesion. And that in the shear wave, it doesn't really depend on the sonographer or the person scanning, because everybody and their strength. We can't really determine that, because the strength I will apply will be more than what someone who is slimmer will apply. And all this, when these strengths are not really linear to the tissue, it can also distort the breast around the lamp, and that can also affect how the pressures within the lamp are displaced. So you see, that one is not really reproducible if different people are doing it. So we have the shear wave one. The shear wave one is like when you put the probe on the mass, then frequency or ultrasound wave is sent through the transducer to the mass. And we have, when it happens, the size can be distorted because of the ultrasound that is transduced within it. So it's not a normal size length ultrasound. It's a high frequency ultrasound that is used to do that. And with that, you can also get size distortion. And we also have what we call color coded. So the color determines whether it's a soft lesion, a hard lesion, or in between. But it's very important that you don't put it in your mind that red is soft, blue is hard, because various manufacturers use different colors. So when you are scanning, you just look at the color map that has been provided, because the color map that is provided at the side will show that this is for hard, the one here is hard, the one here is soft. Then the color that you use will differ. So mostly what this thing does is it tells you, okay, so this lesion that you are seeing, for example, if they say that red is soft and blue is hard, so you see, and between red and blue, maybe there is a green, yellow, you have some other colors. So if a lesion is purely red, after you apply that pressure, it means that this lesion is very soft. And because it's very soft, like in the cyst, it's unlikely to be a cancerous lesion. Then if you check, you say, okay, when you check, it's not red, it's not completely all red, and there's no blue. It's like red and green. And maybe the green is the normal tissue of the breast. The surrounding breast gives a green color. So if the lesion is red and green, okay, this lesion is likely to be benign. It's not a suspicious lesion. So it's like a grade 2 lesion. Then you go to the other one, okay, the mosaic appearance, yes, having a little bit of blue, a little bit of green, a little bit of red, is just mixture. So that one too is also, the suspicion for malignancy is not that high. Then we have one that the center will be all blue, but the periphery will be green. So because we know that, it means that the cancerous lesion is likely to be in the center part. So the suspicion for it being cancer is very high. And we have some that the whole lump itself is blue, meaning the whole lump is hard, but the surrounding breast tissue will still be green. It means that the lesion itself has not affected its surrounding tissue. It's also, that's like a grade 4. But the grade 5 is when the whole lesion is blue and the surrounding breast tissue is also blue. So this elastography just helps, because the issue if we went with this is, we know we use the Barrel system to classify lumps in breast. And this sometimes, if the mass is very small, appreciating the margins to know that it's microangulation, there's microlobulations, or it's angulated, it becomes very difficult. So you're not really sure about your mass, whether it's really a suspicious mass, like a Barras 4, or it's actually a Barras 2, or it's in the middle equivocal Barras 3. So when you do this color coding, or you do this elastography, and you see that, okay, even though this lump, it looks like the margins were fine, but it's given a blue color, it means that the probability of this cancer being a malignant is high. Then instead of you seeing the patient should go with a benign mass, you're able to detect the cancer faster and do something about it. Then we have so this elastography is being applied in breast and thyroid cancers or tumors, and also in liver cirrhosis, because in liver cirrhosis, the liver becomes very hard because of the fibrosis. But that's not our main topic today. That's why I didn't mention that. Then we have the contrast-enhanced ultrasound. This is very important because there are cases that a patient needs a CT contrast study to be done, but this patient's renal function is not good. So if the renal function is not good, it means that we can't give contrast. And the next best method is to do an MRI, because the MRI has good tissue resolution. But most of the times, cancers is good if we have the contrast enhancement. If you cannot give contrast in CT, it means that MRI, you cannot give contrast. Then what do you do? Because these patients, you need to make a diagnosis so you can know how best to manage the patient. That's where contrast enhanced ultrasound comes in. For the contrast that is used in the contrast-enhanced ultrasound, it's not the iodinated one or the gadolinium that is used in MRI. The contrast is just made up of microbubbles that have gas inside. And this does not affect the body in any way. It is innate. So it means that if we have that, then there's no need to say that this patient has a renal problem. So because of that, you can't do contrast study for them. And what this contrast-enhancement does is you have a real time. Because when you give the contrast, you are scanning, so you see the real time what is happening. And with that, you don't have issue with a radiographer doing your triple face and miss the face. Then when you are now reporting, you are wondering, hey, then they've missed the face. I can't get into this patient should come back for contrast again. What do I do now? You are just thinking. Then now you have to think about other things. Ask the surgeon where they've done this test. They've done this enzyme, they've done these tumor markers to come at a conclusion by using everything. And sometimes very difficult because the information may not even be on the limbs. And the doctor who also requested they didn't write the name fully, just did some signatures. So you have no one to contact. The person you contact, the person who does not know about the case. And we're told that, okay, you have to communicate with the team and they'll get back to you. You also have other reports to write, and the person may get back to you 2 days or 3 days time. And all this delay. The patient is saying that doctor said, if you don't get the report, they will not do the surgery. He or she doesn't even understand what is going on. So the contrast-enhanced ultrasound is very good. And because what is that is, specific tumors have the way they appear on the ultrasound. We all know that if someone has a hepatocellular carcinoma and you do a contrast-enhanced CT scan, we know it will pick up, it will enhance in the arterial phase, then it will wash out in the protovenous phase, and the washout will continue into the delayed phase. In contrast-enhanced ultrasound, the washout, the degree or the rapidity of the washout determine whether it's likely to be a hepatocellular carcinoma or metastasis rather. because METS has various appearance on the arterial phase. It can enhance, it will not enhance, you can just do peripheral enhancement. And sometimes, METS also wash out just like ACC. So when it happens like that, you are wondering, is it ACC, is it METS? Then when you give both differentials, you get a call that, especially for medicine team, oh, they want you to clinch on one. And I will tell them, we can't clinch on one. You see, for the MDT team, you need a pathologist. That's the importance of pathologists. No matter how sure you are the diagnosis is this, you always have to have a bias, because sometimes the classic features that you see on imaging may not be there because some have atypical features. So you may think that because of an atypical feature, you may go the conclusion of the tumor being ACC, but it may actually be ACC after biopsy. So you don't always need the radiologist to tell you that it's ACC. If the first gives you differential, open your mind. But I've noticed that people tend to be very narrow-minded in those things because they are saying it is sphincter, it is this. No matter which differentials you give, when they come for a follow-up or they are doing something else, they will choose the one they want and use that as their history. So you said that it was a hepatocellular carcinoma, it can also be MET, it can be cholangiocarcinoma. You get it? Then they will choose that, I think it's ACC. The next time there will come a known case of ACC, then you see that, what ACC are they talking about? So some of these things is very serious, and when the timing also play a problem because the radiographers are not really doing things well, there's a problem. But with the contrast enhanced, as you are there, you are seeing it, okay, this tumor is enhancing. As you are holding the probe, you are seeing it yourself. As people will say, feely, you are watching it. Then you can see that within less than a minute, there was washout. The moment you see washout in less than a minute, it's likely to be METS. But if the washout is slow, progress over time, after a minute, after 2 or 3 minutes, before you start seeing the washout, then it's likely to be a hepatocellular carcinoma. When the washout is rapid, apart from MET, another thing that can do that is also intrahepatic cholangiocarcinoma. So these things, you have to weigh them, which means that you have those 2 diagnoses there, then biopsy will now help you confirm which one it is. So that's what contrast enhanced ultrasound does. Then we have what we call the high intensity focused ultrasound study, which is mostly used for ablation and also image-guided drug delivery. So this is just a case, 11-year-old, a scan was done and they saw a congenital mass in the left lobe of the liver. Then this is a contrast-enhanced ultrasound. You notice that in the arterial phase, this arterial phase, 10 seconds, arterial phase, 40 seconds, protovenous phase, 53 seconds, then this is 120 seconds, that's the late phase. So you notice that this mass, there was a heterogeneous enhancement. Then, as the time increased, you see that the enhancement is becoming more homogeneous. But at 53 seconds, you notice that this area, even though the background is homogeneous, this area still didn't enhance. So it means that there's an area of necrosis. Then the protovenous phase, you start seeing that the periphery of the center of the lesion is washing out gradually. Then the late phase, you see more area being washed out. So this shows that this is hepatoblastoma. So it means that you should read to know what cancer, how each cancer appear on this contrast-enhanced imaging. If you don't read, you see it, but you will not know what it is. So this is case. It was a case of hepatoblastoma in a 11-year-old boy. This is elastography. So in this image, on the grayscale ultrasound, this lamp was seen, and this lamp is hypoechoic. In ultrasound, we say it's hypoechoic when it is dark. When it is bright, we say it's hyperechoic. And you can, this lamp, it has some margins that are speculated. Then elastography was done. You see the color code here. Soft is what? Red. Then hard is what? Blue. Then these are in the middle. So after the elastography was done, or during the elastography, we realized the color code it gave to the mass is basically what? Blue. So it shows that this mass is highly suspicious of malignancy. So this is what elastography does. There's also another mass here, which is also what? it's heterogeneous, but predominantly what hypoequivalent, because you are seeing bright parts and you are seeing dark parts. But the dark parts are more or prominent than the white parts. And looking at the margins, you see it looks like lobos. When you see a lobulated mass, a macrolobulated mass, like big lobos, it means that it's likely to be benign. It's the microlobulations that speak for what? Malignancy. Then elastography was done. And look at it, soft is what? Red again. Hard is what? Blue. And the color of the mass, you see, you are seeing it's a mosaic. You are seeing some green, some red, some yellow. So this lamp is not that firm. So this lamp is a benign lamp. So this was a fibroadenoma. So this is how the elastography works. Then we have advanced radiographic techniques. Then we have digital radiography. And first, because there was no digital radiography, it was just conventional radiography. So after you come and we take the image and you send your films away, that's all. When you come back later trying to get the information, you will not have it. And these patients, they will go and eat and use and put some balls on the films. And by the time you see the image, it is distorted. So it makes it difficult for the oncologist to see whether there's been improvement in the treatment of the patients. So most of the times, the digital radiography is good. It's a PAC system, so the images, no matter how long ago, the images will still be there. So if you want to compare with current image, you can just go and retrieve it. Then we have what we call the automatic picture staging. Some places have short cassettes. So if you want to examine the whole lower limb, you can't really have that being done. So they have to divide, especially when you just look at the eyes. Okay, so from here to the mid part of the femur will appear on the film. So they'll take that part. They will take middle to the knee. Then they will take the knee to the mid part of the tibia and fibula before they take the foot. And first, when it has, then the radiologist will now have to come and arrange it by himself. But this automated stage, what is that? There's an algorithm. So the moment you bring these images, it just arranges and you get a full-length image without you doing anything about it. And it makes it easier for you to interpret or to find any pathology. And we have what we call tomosynthesis. For conventional X-rays, it's just like taking a picture, a static picture. I'm standing there, someone snaps back, and you are gone. But tomography, if I want to take an image of this particular part of the mic, and this thing is in front, you direct the X-ray. So when you direct the X-ray, this will be the focus. Anything anterior or posterior to that image becomes blurred out in tomography. So it's only the area of focus that you are able to see in tomography. So the moment I decided now I want this one, this pointer I'm using to be the area of focus, then this one becomes very bright. Then the mic stand becomes what? Blurred. So this is how tomography, and that's what is used in both CT and tomosynthesis. So when it comes to tomography, it's very important in breast imaging, because in breast imaging, when you do just a normal 2D mammogram, there are a lot of superimposition, especially in those who have dense breasts. So when you have the breast density being so high, you are not able to, it obscures small masses, and you're not able to see them well. So what tomography does is, instead of the X-ray and the way just taking an image like this, it just takes a spot image. What it does is, it takes slices of the image, like 1 millimeter apart. So even though you are in the machine and the duration is almost the same, if you use 2 to 3 seconds in normal mammography, in tomosynthesis, you will use like 3 to 4 seconds. So the difference is just about 1 second. But you realize that in normal mammography, you have 2 images for right, left, mediolateral oblique, then piniocaudal, right and left. But in tomosynthesis or in the tomography, you end up having about 250 images because you have slices 1 millimeter apart. When it does that, the issue of summation that you have is reduced. So now people are even moving away from using just 2D mammography to do breast cancer screening for those who have dense breast. They do tomosynthesis rather. Then from the tomosynthesis, they can generate a 2D mammographic image from it. So this is the limb stitching I was talking about. Here you have the full image. And this under tomosynthesis. So this patient is known to have skin melanoma. And the chest X-ray was done. And this chest X-ray, you saw this thing there. And this opaque thing there. And we said that it was what? A nodule. If it was here, so far it's a nodule, then we just go straight that it is what? Metastasis. And that will be the end. If the person can afford CT, they will go and do, but someone will be like, just one nodule, why should I go and do CT scan? And they'll just say that we just manage as met. But when tomosynthesis was done, it was noticed that it actually wasn't a nodule. It was just at the costochondral junction, the cartilage there as hypertrophied, and that it was giving the impression of it being a nodule. Are you getting me? So you see the importance of using urine. Because I noticed that in this country, we are used to using just one imaging modality to make diagnosis. So you have people asking for second opinions. Why? Because someone saw and gave plenty differential, but they don't want to go and do further imaging to rule it out. In a situation where even PET scan is not available, it's so difficult because sometimes it's a cancer case, then you see some infiltrates within the lungs. And this infiltrate within the lungs, we all know that if this patient didn't have cancer, we just go straight away and say that it's pneumonia. But this patient has cancer, and MERS too can present as what? Infiltrate. So you come in and give both differentials, you get, no, why isn't it MERS? You try to explain that, I can't stick my head out, they don't want to agree. But in outside world, when they see that the development countries, they'll just go and do a PET CT scan and see the uptakes within the infiltrate, and they'll say that, okay, it is MERS or it's not MERS. So this is just talking about the tomosynthesis that I've mentioned already. So, as I said, the X-ray tube draws an arc over the breast, and it takes slices of the breast tissue. So this is just showing you tomosynthesis images, so slices of the breast tissue. So let's look at this case. This patient had a conventional 2D mammography done, and looking at everything, we just passed it off as a normal breast. But tomosynthesis was done, and you realize that there's an architectural distortion here. As the slices numbers increase and the image quality also improved, you notice that there was actually a radiodense mass here with speculated margin. So this mass is highly suspicious for malignancy. If you see a speculated margin, it's Beresford-C already. So without the tomosynthesis, this patient would have been sent back and said that, okay, it's normal, so go home. Then when they come back a year later, the mass would have metastasized already. So this is the importance of tomosynthesis. And this whole country, you only have one center. So I think, so this is just looking at the parameters. Somehow will be like, there are plenty slices of the breast being taken, so it means that the radiation dose that you receive will be higher. But no, the radiation dose is not that high. It's about 1 to 2 times of the one that you need for mammography. And the compression, the same way normal 2D mammography is done, where the breast is compressed between 2 parts. That's the same thing that is done for tomosynthesis. But just that the availability, mammography is, the normal 2D mammography is common or more available compared to the synthesis. Then the limitations, the normal mammography, there are issues with the summation of the breast tissue, but those issues are offset for tomosynthesis. The duration of study, not much different, 2 to 3 seconds and 4 seconds, not much different. So intervention, what does interventional radiologists have to play in MDT? So you can do image-guided biopsies. So you scan and you see that there's a lump within the breast, there's a lump within the thyroid. You just have to, using your ultrasound, you guide a needle, your biopsy needle into the mass, and you take a chunk of it and take it for the pathologist to evaluate. We also have what we call arterial embolization techniques. So the arterial embolization techniques, Most of the time, it's very important for patients that the cancer has reached a stage that is not resectable. It's unresectable. And this mass is very big and it's causing pain or is bleeding. So what you do is, the interventional radiologist will guide the catheter into the vessel that supplies that particular mass. Then use coils or substances to block the blood flow to the mass. Because the blood contains oxygen and nutrients, when the tumor misses those things, it will start to shrink in size. So when it shrinks in size, for example, for renal tumors, when it's so big and it stretches the capsule, there's too much pain. So if you have the tumor shrinking in size, it means that the mass effect of the enlarged mass on the capsule is reduced. So the pain that the patient used to feel now goes down. If it was causing bleeding, because you've cut off his blood supply, the bleeding or the hemorrhage also stops. The arterial embolization, we also have what we call the chemoembolization, where when you advance the catheter into the mass, you inject a chemotherapeutic drug into the patient. Then we have what we call the ablation techniques. The ablation techniques, you just use, by using ultrasound guidance, you advance a needle into the mass. Then you can do either cryoablation, where you give a cool substance like helium or argon in hope of shrinking and making the mass die. Then you can also do the thermal ablation, where you give electromagnetic wave or use electrical current in hopes of firing the lesion or the tumor and making it die off. Then we have the gene therapy. I think that's what investigations are being done on at the moment, because as humans, the basic genetic makeup is contained in our DNA. Who you are and the fact that you are black, you are fair, you are multicolored, it's all due to your DNA, the gene in your DNA. So what this one is trying to do is, okay, we say BRCA1 and BRCA2 gene, when you have those genes, you are prone to having breast cancer. So they are trying to target, look at where those genes are and delete them, clip them, splice them off. So that if you don't have those genes there, it means that you will not develop the cancer. I hope you are getting me. So that's the main thing. And because radiologists, we are used to entering smaller places with our needles, and we are also involved in that. So currently, that's the study that is undergoing for the management of cancer. This is just showing you an image. So there is a CT scan, and this is CT scan. You saw this mass in the left lung. Then you can see that a needle is being inserted into the mass. I hope you can appreciate the tract of the needle. So you can take a tissue of the mass and take it for pathology to diagnose whether it's a cancer or it's not a cancer. This is a case, this patient had HCC, and what you know, the liver gets 80% of its blood supply from the portal vein. The hepatic artery hardly really play a role. The hepatic artery tends to supply more of the ACC. So it means that if it cuts off the blood supply of the hepatic artery, the liver will still survive if the portal vein not supply. So this image, it shows that when this patient has a hepatocellular carcinoma, and you can see this tumor blush, this darkness or plenty vessels around this area. But after a chemotherapeutic agent was injected into the artery, you notice that the blush that was there is no longer available. The blush is this. I don't know whether you understand the terminology I'm using. You see, there is this faint darkness or blackness at this area, but in this image, you are not seeing it again after the agent was given. So we'll just take our first case. It's a 41-year-old female who presents to the GP with a progressively increasing right breast lump of 6 months duration. No significant weight loss or night sweats. No known positive family history of breast cancer. On examination, there is a young female, not pale, not cachectic or paresthesia. A firm node was detected in the upper outer quadrant of the left breast. Another firm node or nodule was detected in the periareolar region of the right breast. The basic labs that were requested were the FBC. Then mammography and ultrasound of the breast was requested by the physician. So this is the mammographic image. This is a mediolateral oblique image. And for the mammography, for the MLO image, up here is up, down here is lower. So it means that this mass, radiodense mass, is within the upper half of the breast. If you have the CC image, before you get to know whether it was in the inner or the lateral part of the upper half of the breast. We don't have that image, so we just work with this. It's in the upper half of the breast. So a scan was then done. And when the scan, ultrasound scan was done, it showed this hypoechoic elation with some angular and spiculated margins. So this means it's a Barrett's 4 lesion already, which means that it is suspicious for or suggestive of malignancy. So biopsy was done under ultrasound guidance. So you can see the lump here. This is the tract of the biopsy needle. This is the tract coming. It has entered the mass. And you can see that the size of the mass after the biopsy has even, the biopsy needle has entered has also shrunk because they've taken a tissue out of it. Then a chest, when the diagnosis was made of it being a breast cancer, a chest X-ray was requested, and also a lumbosacral spine X-ray was recommended too. The chest X-ray came back normal. It means that there are no lung mets. Then a lumbar spine X-ray was requested. When it comes to this, it's very important because sometimes some of the features are subtle. If you look at this image, I hope you can all see this thing. These eyes, and we call them eyes, they are the pedicles. That's where most of the times, when they are met, they tend to go to those places. Then you see this nose. So in all images, all spinal images, you are supposed to see those eyes and those noses. The moment you lose them, it means that there's something happening there. So you notice that in this image, you can see the eyes, you can see the nose, I can see the eyes, I can see the nose, I can see the eyes, I can see the nose. Where is the left eye here? It's missing. So it means that it's likely that there's met to that particular part of the spine, and that's the L1, because this is your last rib, so that's your T12 vertebrae, and this will be your L1, your lumbar, the first lumbar vertebrae, so there was met to that vertebrae. So this is the role that radiologists play. So because of that, it can even help, it will help in staging the breast cancer lesion. Then case 2, a 72-year-old male presents to the accident and emergency with acute retention of the urine that has started that evening. Prior to that, he has been experiencing dribbling, failing of incomplete bladder emptying, and urgency. A urethral catheter was passed immediately for relief. Then bedside ultrasound was done. So the bedside ultrasound, this is the prostate gland. And this prostate gland is enlarged. You know, the moment you see prostate gland enlargement, the first thing that comes to your mind is what? BPH. I'm sure BPH. I think it only clicks that there's something going on. If the patient comes with this urinary problem and says that I'm feeling back pain, then someone will be like, hey, before there's back pain, even though this patient is aged and it could be degenerative change, you start thinking about the fact that, hey, what if it's cancer? Then now you request for the PSA, then you go and do other things. So most of the times, what was being done is, when you see this lump, you just go in blindly, take go to this segment and take some tissue. Then hope that you'll be able to, if there's cancer, you'll be able to pick it up. But you see, you can see a lot of nodules in the enlarged prostate, and these nodules may not necessarily be cancerous nodules. They may just be hyperplastic nodules from the BPH. So you need something that will guide you to know that you go to this particular place to pick up the tissue for your pathologist to examine, because that area is likely that that area has the malignant lesion. And this is where multiparametric MRI comes to play. So that's why when I see someone saying BPH and comes to request CT, I feel like my heart is beating, because you have no feature, now you just come in. And I also reply back to you that poster, Megali, go and do MRI. You get pissed off that he didn't say anything. You see, I've been getting calls, he didn't comment on the prostate. I didn't comment on it for what? I've told that it's enlarged. So you didn't tell me that it's cancer or BPH. Now, we don't use that for imaging to test. So if you want to know that it's a cancerous nodule or it's a benign hyperplastic nodule, please, the imaging to do is multiparametric MRI. Multiparametric MRI. And not just normal MRI. The multiparametric one, apart from you being in the MRI gantry, you also have to use endorectal call. So sometimes you go to some centers, they'll tell you that they know how to do it, but they'll go and do just normal pelvic MRI for you. So if any relative go ask them, did they put something there? If they didn't put, then you know that they didn't do the right thing. So this patient, MRI was requested, CT scan of the chest was also requested, then pelvic X-ray and PSA. So this is the MRI image. This is the T2 weighted image. This is the DWI. This is ADC. So most of the time for prostate cancer, the nodules like to be in the peripheral zone of the gland. The benign prostatic hyperplasia, the nodules tend to be within the transitional zone. Tend to be in the transitional zone. And when it comes to prostate cancer, they tend to be dark, that's hypointense on T2 imaging. Then on the DWI, they show restricted diffusion. If you say restricted diffusion, it means that the lesion appears white on DWI and appears dark on ADC. I'm just using the terms so you understand. So this is the lesion that was seen. And you will look at this is the DWI. There's a bright area within the lesion. On the ADC, there's a dark area. So it means that this lesion is showing restricted diffusion. So it's likely that this nodule is a cancerous nodule. So because you know where the location is, and you know that with all the nodules you are seeing, it's only the 1 year that is cancerous. It will also help the person doing the biopsy to go and target that area to take the tissue. And will not just go fishing around, just taking tissue everywhere, trying to hope that those tissue he or she takes will be the cancerous tissue. Because otherwise, people are being managed for BPH, but they actually have prostate cancer hiding somewhere. So the pelvic X-ray came, and you will see that this patient, L4 vertebrae, is whiter than it should be. So it means that it's sclerotic. Then there are also some white lesions. These white lesions are what we call the sclerotic lesions. So it means that the prostate cancer has already metastasized to the bones. But because only a pelvic X-ray was requested, they requested for a bone scan to see all the bones in the body, to see the extent of the bone involvement of the breast, of the prostate cancer. So the areas that you see that are dark, these dark areas, increased uptake, these are areas that the tumor has spread to or has metastasized to. So this is a bone scan showing that this patient has a prostate cancer and with bone metastasis. So the conclusion now is radiology has a big role to play in multidisciplinary team. And the role is not only up to the radiologist to clench the diagnosis. I think that's the key word I want to use now, clench. You always need to have a biopsy done, no matter what we say is the diagnosis, so that you won't be managing something that is not, because some features are classic, all right, but there are times that may have atypical appearance, and there may be times that you may also, the faces may escape, because not every time that the imaging can be done right. So if you don't do these biopsies, it can affect how you detect these cancers early, and also how you can manage them. These are my references. Thank you.
you've really educated us this morning. So, first of all, there are some housekeeping information. The washroom is just on your left, just after the gate. There are also some QR codes on each table. It has the program lineup on it, so you can scan it. If you have issues scanning, you let us know. We'll go for a short snack break, 10 minutes, then we'll continue the program afterwards. So enjoy your snack break. Hello. Please welcome back to the second part of the program. Our next presenter is online, so as Dr. Ajuman said, for the MDT, there are some core team members, and one of the core team members are the surgical members. So Professor Mason is online to give us the principles of oncological surgery and the impact on organ preserving in treatment. So basically, if he can share a slide now if he's online. Please, if you have any questions, just note them down. I have a few myself, and after the presentations, we'll have a time for questions and answers before the case presentations are done. So just note down your questions. Those online too, you can put it in the chat box. We'll read it out during the question time. Please, if you're outside and you're taking your snack, you can bring it in so that we can proceed.
Okay. Dr. Berry, can I go ahead?
Yes, you can. We can hear you live.
Okay, I'm getting some feedback.
Well, we can hear you.
Whether it's still okay.
We can hear you clearly,
All right.
so you can go ahead.
Oh, okay then. Thank you very much. And good afternoon, colleagues, for the opportunity to do this presentation. I actually intended coming to do it in person, but I had to also be in a meeting on campus. So just permit me to do this online. As Dr. Furi rightly said, a very important stakeholder in the management of cancer patients is the surgeon. And so it's important that as we discuss the management of cancer patients, we look at the surgical principles that underlie the role that surgeons play in the management of cancer patients. Surgery, as we know, when it comes to solid tumors, is probably the mainstay of management. And a lot of patients who have solid tumors will certainly need to go through surgery. Even with the multimodal cancer therapies that we have, surgery is almost always one of the key components of the management of cancer patients. And so the surgeon has a very big role to play when it comes to cancer care. One of the things that the surgeon does is that he must take care of the local tumor and the regional tumor. So the primary disease and locally advanced disease will normally have to be handled by the surgeon. And so in wanting to do that, you find that the surgeon very often will try to get rid of the organ that houses the tumor. And if there are adjacent organs, they may also get involved so that they are taken out, or structures that are near to the organ that houses the tumor. And the regional lymph nodes that may be involved will all have to be taken away by the surgeon. And very often, this is what the surgeon will do. These days, it is also becoming popular that for some metastasis, for example, when people have rectal tumors and there are mets to the liver, it's possible to go and excise the mets from the liver In urology, if there is a renal cell carcinoma and there is mets to the lungs, we can go and excise the mets from the lungs. And so disease surgeons will also go after metastatic lesions and remove them as well. That may not be all. The surgeon is also very important when it comes to getting tissue for diagnosis. Surgery may also be employed for palliation, where the tumor cannot be cured, and sometimes just to reduce pressure symptoms, etc., or sometimes just to improve quality of life. For palliation, surgery may be involved. Surgery is also important these days. When somebody has a very big predisposition for a certain tumor, they may undergo prophylaxis surgery. For example, people are doing mastectomies prophylactically if genetically they are found to have a very strong risk of developing breast cancer, for example. So surgery is very important in the management of cancer patients. However, the role of surgery in management of cancer seems to be changing over time. A few, maybe some in the 19th century thereabout, surgery was probably the only weapon that was available to the medical society for the cure of cancer. But we know now that surgery is just one of the weapons that we can employ in the management of cancer. Again, surgery used to be the first line treatment for all cancer cases. But these days, it is possible that surgery may not be offered first and can even move all the way to the third line of care for cancer patients. And then also, the surgeon today does not manage cancer patients solely, but surgery must be done in a multidisciplinary team approach. And so the approach to surgery or surgical care for cancer patients seem to be changing. And for that matter, the surgery that is also offered to the cancer patients is also changing. The traditional wisdom has been that the more radical the surgery, the better the outcome oncologically. And so you find that surgeons will have to remove so many organs, do a very extensive resection, and that seems to suggest that we will have a better oncologic outcome. For example, in urology, if you are undergoing radical cystectomy, almost every organ you have in your pelvis will be removed, and we will do lymph node dissection all the way up to the common iliac, for example. But these thoughts are being refined today, and surgeons have to appreciate that because of the availability of other forms of treatment, the extent of surgery is slowly changing for cancer patients. Yes, by all means, surgery must aim at an R0 resection, where you don't even leave microscopic tissue behind. But so as to limit the extent of resection, people are depending more on frozen sections now. We are doing sentinel lymph nodes, etc. And these are strategies that are helping us to be able to save some tissue which does not necessarily have to be removed, because the traditional thinking that you have to remove very wide and that will guarantee a better oncologic outcome has been found in today's world with all the other forms of cancer therapy available not to be necessarily the case. And so it is becoming a bit more limited now. Again, pre-op oncological treatment is playing a very important role on the extent of surgery that should be offered to cancer patients. One of them is that the free resection margin is now being redefined. Until now, even when a patient has had pre-op treatment and then the surgeon goes to operate, the surgeon will still go for a very wide radical excision. But today it has been found that if the patient has gone through pre-op resection or any form of pre-op treatment, it could be chemotherapy or whatever, when you go for surgery, you can limit the extent of excision. The fear that even tumors, resection margins that were free of tumor could still have some cancer cells which were viable, is now found not to be so. And so the resection margin has significantly been restricted, and people are actually now restricting things like breast cancer surgeries, post new adjuvant treatment to about 1 millimeter margin, for example. That has also led to a reduction on the extent of tissue that is being removed. So we know that if, for example, you had a gastric tumor and you were going for resection, they needed about a 5 cm, 6 cm resection margin. But today, that has been reduced very low. You can even have a T3, T4 gastric tumor after some pre-op oncological treatment. If the patient is going for surgery, something that would have required you doing a total gastrectomy, one could now do a sub-total gastrectomy and still leave some proximal gastric tissue behind. And so pre-op oncological treatment is actually now redefining the extent of surgical excision or surgical resection that we offer to patients with cancer care. Another thing too has been that the effectiveness of pre-op oncological treatment is redefining the prognostics of cancer patients. So previously, even when a patient has had pre-op treatment and is going for surgery, the prognosis was still being defined based on the stage of the cancer before the patient had the pre-op oncological treatment. But it's been found that for most cancer patients, breast cancer, rectal cancer, etc., the stage of the patient after the pre-op oncological treatment will normally be the one that will define the prognosis, so that if the pre-op oncological treatment is able to downstage the tumor, the patient's prognosis will be similar to a patient who presented with a stage of tumor at that new stage, and will not necessarily be like it used to be before he had the pre-op oncological treatment. So based on that, it is also affecting the extent of surgery that is offered to patients. Another thing that pre-op oncological treatment is doing that has revolutionized the surgery we offer to cancer patients is that surgeries or cancers which were deemed not to be resectable are now being operated on after pre-op oncological treatments. And in fact, this is why they now want us to use the term pre-op oncological treatments, because it's been found that it is possible to give pre-op treatments to patients who have unresectable tumors to make those tumors resectable, what they now call conversion treatment. And that is a little different from neoadjuvant treatment, where the surgery was initially resectable, but you gave some form of treatment to try and maybe downstage it or make it easily operable. And so now we can have conversion treatments and then neoadjuvant treatment. And the two put together will be pre-op oncological treatment. And so surgeries or cancers which were not resectable can now, with pre-op oncological treatment, be made resectable, and not only resectable, but resectable even with curative intent. And so a lot of things are changing so far as the approach of surgery to cancer patients is involved. Again, one of the dogmas that we had was that you cannot go and remove a metastatic lesion when the primary lesion is still present. But again, because of the effectiveness of some of these other forms of treatment, it is possible that if the metastatic lesion is life-threatening or causing severe impairment to the quality of life of the patient, it is possible to go after the metastatic lesion even before going surgically to resect the primary tumor. And so the pre-op oncological treatment has actually caused our thinking and our approach to surgical care for cancer patients to be redefined. Another thing that surgeons do during surgery for cancer patients is to remove lymph nodes. And we all know how important it is to remove lymph nodes. In fact, there are some tumors that have clearly been determined to have a better outcome in terms of survival and patients' well-being if the lymph nodes are also removed. For example, when you do a mesorectal re-excision of rectal cancer, we know that the 5-year survival improves far better than if you did not. In urology, we know that for bladder cancers, if there are lymph nodes involved, the more lymph nodes you remove, the better the outcome for the patient. But having said that, there is now a new school of thought which is coming up, which seems to be opposing the traditional view, where we felt that the more lymph nodes we removed at surgery, the better the stage finally, and also the better the survival. The new thinking that is coming is that because cancer is a systemic problem right from inception, it is not necessarily the removal of the lymph nodes that improves the survival of the patient. Yes, it will help with the pathologic staging of the tumor. But when it comes to survival, people are beginning to think that not the extent of lymphadenectomy per se, but then because the lymphadenectomy will help us with the eventual staging, we are able to stage the patient better. And having staged the patient better, we are able to give the most appropriate adjuvant therapy that the patient will require. And that rather seems to be where the benefits in terms of survival is coming from, and not necessarily the fact that we did an extended or we did a very radical lymphadenectomy. This is not settled yet, but just to let colleagues understand that the traditional view that let's go very wide is being seriously challenged, and people are coming up with different thoughts because of improvements in other forms of treatment that are available for cancer patients. This was a study that was done by the American Cancer Society. They formed an oncology group, and their oncology group sometime in 2014 did this study. Until this time, whenever there was a breast cancer patient and the cancer patient was found to have even one or two positive lymph nodes in the axilla, then it meant that the patient was to undergo a complete axillary lymph node resection. But in this study, for patients who had T1, T2 breast cancers, they did the sentinel lymph nodes excision. And then for some who had just about one or two sentinel lymph nodes involvement of the tumor, they did a radical excision of lymph nodes in the axilla. And then there was another arm where they also had positive lymph nodes, but they left them and didn't do any radical excision of the lymph nodes, but continued with the other forms of treatment. And after 5 years, they realized that, in fact, those who didn't have the lymphadenectomy even did better than those who had the lymphadenectomy. And so after this time, it has become the norm that complete axillary lymph node dissection offered no additional benefits to those patients with T1, T2 breast cancers who had just one or two positive lymph nodes in the sentinel lymph node biopsy and didn't have any extracapsular extension of the tumor. Of course, you wouldn't do this when the lymph nodes are palpable or when you have a T3, T4 tumor. But this then means that, unlike previously, where it's because a sentinel lymph node was positive, then level 2 axillary lymph node dissection for the breast cancer patient. Now, even if one or two are positive, it is still possible not to do the axillary lymph node clearance, and the patients will do well. I think I have mentioned this already, but again, because of the availability of other forms of treatment, it is possible to go and do creative resections for metastatic lesions. And when we want to do this, we need to be sure that those metastatic lesions are accessible and the surgery to excise them is safe, because there are other forms of treatment available. In fact, I came across one study where even for patients who had very advanced disease, they looked at patients with I think gastric tumor who had who had peritonitis or ascites, and after some pre-op oncological treatment, the ascites resolved, all the tumor deposits in the peritoneum were completely gone. There was a very good response. And so they were able to offer the patients surgery, and the patient's outcome was good. There was a series like that. And so the platforms of treatment actually helping to redefine our approach of surgery to cancer patients. So we want to say that because also of the effectiveness of adjuvant systemic therapy and even of radiation therapy, it is possible that there will be improved disease-free survival and improved quality of life for patients who have had surgery just to remove the gross disease. And these days, people are beginning to see that the role of surgery is more to reduce the tumor burden. And then with the hope that the non-surgical therapies will try or will be effective in eliminating microscopic residual disease, which therefore will prevent recurrence of the tumor. And so, because these things are becoming very effective now, the role of surgery is becoming a bit more limited and not as radical as it used to be. Forgive me for the background noise. I'm not in a very secluded environment. And so for over the past few years, we have found that the major improvements in our own operative technique and the fact that we are doing combined therapies for our patients has significantly reduced the morbidity and mortality associated with our surgical treatment of solid neoplasms, because it is becoming less radical than it used to be. And so surgeons should increasingly manage their patients in a multidisciplinary team approach. This was a write-up that was done, and they looked at radical mastectomy versus breast conservation and oncoplastic surgery. And they realized that saving the breast tissue for most patients who were having the indication for it actually improved the quality of life and everything else, including survival. This was done for bladder cancer patients. These were patients who had muscle invasive bladder cancer. Our teaching has been that if there is muscle invasive bladder cancer, the patient surely must undergo a radical cystectomy, where we remove everything in the pelvis and do a lymph node dissection. But here, these patients, although they had muscle invasive bladder tumor, did not have any lymph node involvement. And they looked at the radical cystectomy versus those who had concurrent systemic therapy and radiation therapy after they had done a transurethral resection of the bladder tumor for them, just in trying to save the bladder. And the outcome was that those who had the trimodal therapy and had their bladder preserved had a better quality of life, and they survived in fact, even better than those who went through radical cystectomy after 5 years. This is a similar finding that they obtained for patients who had rectal cancers. So the message is that where it is possible to combine treatment to save an organ and limit the radicality of our surgeries, today it is better to do that than to remove all the tissues and remove every organ, sometimes including contiguous organs, which may not even have the tumor in them at all, just because of the fear of local recurrence of the tumor. This was trying to look at some of the factors that improve patients' adherence to cancer treatment. And they realized that one of the things the patients think about is their quality of life. And when the patients get to know that when they go through treatment, they will get an improved quality of life, then they will undergo or they will adhere to treatment. And one of the major factors that influence the quality of life is organ preservation. One study I came across realized that married women with breast cancer were more likely to go through surgery or to go through treatment for their breast cancers than unmarried women, simply because the married women, because probably they have had, they are now married, maybe have had their children, did not fear losing one or two breasts. But the unmarried woman knows what it means not to have a breast in terms of even getting a life partner. And so married women were more adherent to treatment of cancer for their breast than unmarried women. And so organ preservation plays a very important role in maintaining the patient's quality of life. And it is one of the factors that the patients consider when they are thinking about going with our care when they have cancer. And so if it is possible, we should do everything we can to preserve organs for them. So when you look at how surgery for cancer has evolved, you realize that in the beginning, somewhere in the early parts, maybe the 18th century, thereabouts, when people started to perform surgery for cancer, the surgery was limited to only the tissue that was involved. In fact, it was just the gross tissue with the cancer that was taken away. But not long after they started doing that, they realized that they had high rates of recurrence of the tumor. And so the understanding came that we needed to do very wide radical resections. And that is why we have been trained to be doing very wide radical procedures. And in fact, when they started doing extensive radical surgeries for cancers, the rates of recurrence went down and the patient's survival improved. But we are slowly coming back to what it used to be in the past, where surgery is now again becoming very limited to the tissue. But this time, it is not just that, but in the environment of multimodal therapy, where we have other forms of treatment that will be able to completely take care of the cancer. And so surgery for cancer has actually gone through a circle. And we have moved from where we focused only on the tissue with the cancer to going way beyond it. And we are coming back slowly to focus now, probably again, only on the tissue that has the cancer. That is all because now we understand cancer better. We have developed our systemic therapy. We have hormone therapy, immunotherapy, chemotherapy, you name them. And they are very effective now. We have radiation therapy, which has improved a lot. And we are now focusing more also on patients' quality of life as much as also on their survival. And that means that more breast conservation surgeries instead of mastectomies. That means that we can save limbs and not amputate them. And for urology, we can save men with their sexual function. We can save their urinary continence. We can save bladders, etc. for most patients when previously we would have taken them out. So to conclude, I will say that when it comes to solid tumors, you cannot take away surgery. surgery will be involved in the care of the majority of patients with solid tumors. But with the development of preoperative oncological treatments, and with the fact that these treatments have become very effective, even also in the adjuvant stage, surgical treatment for cancer is still being re-evaluated. And we are getting to the point where we will be doing fewer radical surgeries and we'll focus more on organ preserving surgeries, and that will probably improve on the patient's quality of life. So I will end it here and say a big thank you for your attention.
Thank you very much, Professor, for that wonderful presentation. Unfortunately, the question time is at the end of all the presentations. So maybe we'll let you know so that those who have questions for you, we'll let you answer them during the question time. Thank you very much, Prof. Mason. Please let's give it a round for him again. So we'll move on to the next presentation. We are now dealing with the core team members. So one core team member is the pathologist. So we have Dr. Kofi Ozin appear to give us a talk on the impact of synoptic pathology reporting and molecular profiling in modern cancer care.
Okay, so good afternoon, colleagues. Okay, so this afternoon we are going to look at the impact of synoptic reporting and molecular profiling in care of cancer patients. And basically what we are going to look at is how the evolution of synoptic reporting has helped with increasing the completeness and the usability of surgical pathology reports, and also how the evolving understanding of tumor biology or genetic mutations which drive the growth of tumor can be visualized as a target to help with improving patient outcomes. So we all know that cancer treatment increasingly depends on precise or accurate pathology data, which most of the time would be reported or you would receive as a report. And the multidisciplinary team meetings require consistent and complete actionable reports. So most of the time, if you have or you are in possession of a surgical report which has some missing data, or it is ambiguous and you can't appreciate the content, it makes it very difficult to form decisions during MDTs. So basically what we are going to look at is how the synoptic reports, so I'll talk a bit about that in the subsequent slides. So how synoptic reports and molecular profiling offer efficient data analysis. So in the scenario whereby the clinician wants to access certain parameters or certain data from the report in research, or in the scenario whereby we need to update our cancer registry, it makes this very easy for the process to go on. And aside that too, once we understand the molecular profiles of the tumors that we are treating, then it can now direct our precision medicine initiatives, which is of interest to the oncologist. So what is synoptic reporting? So a synoptic report is basically a structured checklist which contains required data elements, and for each required data element, there's supposed to be a response. So it kinds of structures and standardizes and summarizes the pathology report, which is much usable for the clinician and also the oncologist. So over time, this synoptic report has replaced the traditional free text or narrative pathology report, where for the pathology report, most of the time you'd have a macroscopic section. So it's in 3 sections. The macroscopic section, which is the gross appearances of the tissue that we have received, and also the microscopic section, which would contain the microscopic findings that we are reporting from examining the tissue slides. So over time, this has replaced the free text narrative, which you get to know that contained a lot of errors, and these errors were either typographical errors, semantic errors, or errors of omission, and usually were not standardized. So depending on the style of the pathologist or who is reporting the case, you may have different interpretations or different reports for the same tissue that you are examining. So this synoptic reporting ensures that the reports are complete, because you need, at the end of the report, you should have, you are required, or you should have answered all the required data elements with responses, which will ensure that you are issuing a complete report and it offers some consistency. So irrespective of the style of the pathologist or how the pathologist will narrate what he or she is seeing with the case, it would make it consistent. So an example of these synoptic reports are the ones which have been produced by the College of American Pathologists and the Royal College of Pathologists of Australia and the UK. And basically what they have done is that they have come out with protocols for the various types of primary tumors. So for each primary tumor, example, breast tumor, colon cancer, prostate cancer, renal cancers, we have protocols or checklists that ensure that after you have completed your report, you are issuing a complete standardized report. So let's have a look. So as I mentioned, so traditionally, most of our pathology reports were the free text or narrative form, where you have the macroscopic description and also the microscopic description. So you can see how laborious or the process is to read all this to be able to acquire certain specific data or information that you would require to make your decision during the MDT. So at the end, we would usually conclude with the pathological diagnosis. So this evolved over time, and we now have the synoptic report. So you can see how friendly this report is, where you have the macroscopic description, which kinds of summarizes what we are seeing grossly. So this is what I mean by the required data elements. So example, it's not too clear, but if you look, you see that there is specimen location, or where the tumor is. So in that case, you need to answer per the laterality. Is it left or right? Instead of where you have a report that says that received a mastectomy specimen with a tumor in the right breast. So it's kind of laborious. So for each required data element, you would have a response. So at the end, it makes it much easier to be able to retrieve data. If you want to conduct a research where you want a quick guide, or you want to quickly find the number of tumors which were found in, let's say, the left breast of a patient. So it will be easier to get your information from this kind of synoptic report. So similarly for the microscopic description, instead of having your free text or narrative where there may be prone to errors, either errors of omission, that's forgetting to input some data or not completing your standardized report, you have this where at the end of the report you would have to answer each required data element. So at the end, it ensures that you have completely gone through the process, and this report would be usable for your MDT. So what are the benefits? So as I mentioned, it improves clarity. So there's no ambiguity or there's no ambiguity for clinicians. So once they go through the required data elements, it's kind of clear information which is being provided to them. Aside that too, it will improve the completeness of the reports, whereby it will enhance the efficiency of the MDT meeting. Aside that too, it will facilitate cancer registry. So it helps with easily gathering data for cancer registry, and also it makes research purposes very simpler. Imagine if you have to go through all this text in both microscopic and microscopic descriptions to be able to just detail or get some unique information that you want. It's kind of laborious. So the benefits of synoptic reporting, aside enhancing the care or the patient or improving the outcomes for the patient through the completeness of the report, it's also friendlier to the user of the report. That is either the researcher, the clinician, the oncologist, and the patient who owns the report. So what is molecular profiling? So basically, molecular profiling is a concept whereby we are trying to decode or unmask the tumor. You know, most of the time when it comes to tumors, what we consider at the primary level is the morphology. So how is the tumor appearing? Is it appearing as a carcinoma? Is it appearing as a sarcoma? Is it a lymphoma? But we will get to know that with respect to treatment of cancers, this alone is not enough. We need to decode or unmask the tumor to understand the mutations or the genetic deficiencies which are driving or which is driving the growth or proliferation of this tumor. And basically that is what is molecular profiling. So basically the aim is to identify DNA, RNA, and protein alterations which may either be mutations, fusions, deletions, or whatever that would result in the proliferation or the growth of the tumors. So how this is done is that it is either by the use of the tissue, so tissues that you would have accessed from the tumor, and usually would be formalin fixed and paraffin embedded. So either tissue from tissue blocks, or most recently there is this drive for liquid biopsies, whereby a blood sample is taken from the patient who has a tumor, and the aim is to identify these DNA, RNA, protein alterations in the cancer cells which have been shed into the bloodstream. So the molecular methods, usually molecular methods would help us identify these alterations, and commonly what is used now is the next generation sequencing. So either the next generation sequencing or your PCR or your polymerase chain reaction will help you identify these mutations. Aside that too, we have the immunohistochemistry, which helps us identify proteins or abnormal proteins on the surface of tumors. And examples of these mutations will include EGFR, which is now imperative, or it's important that you identify if you have a patient who has a lung cancer, and KRAS mutations for colorectal cancers, HER2, as we all know, for breast cancer. So for HER2, most of the time, the IHC would be enough to determine whether a patient would benefit from targeted therapy. But in the scenario whereby the IHC is not sufficient, either due to the score, so if it is a +2 or less, then you need to perform this molecular method to determine whether there's overexpression of this gene. So once there's overexpression, then the patient can benefit from the treatment. And we also have your microsatellite instability and your PDL1. And PDL1 commonly now has a role in immunotherapy. So its presence would help determine whether a patient would benefit from immunotherapeutic agents. So why does this matter? It matters because it transforms our guesswork to guided precision. So imagine if you have a patient who has a lung cancer and you are unable to perform or decode or unveil or unclose the tumor to see whether there are these mutations which is driving the growth of the tumor. It means that what you have available to you is a baseline chemotherapeutic agent, which aside targeting the tumor, can also affect your normal tissues, you understand? So if you have any rapidly proliferating cells in your body, the chemotherapeutic agent can also affect these cells. So basically, if we are able to identify these mutations, then it means we can target the tumor with formulated or targeted therapies, which will be directly targeted towards the tumor and kind of improve the patient's outcome and reduce some of these unwanted or side effects. So aside that, it helps us predict the cancer behavior and also response to specific treatments. And lastly, it will guide our treatment decisions during NDT. So if you have a patient who manages or is able to perform some of these tests or has a molecular profile of his or her tumor, then it means that it's likely that the patient can benefit from these targeted therapies and would improve the outcome of the patient. So in practice, so practically, as I mentioned, so when it comes to lung tumors, so commonly we have the non-small cell lung carcinomas. So if you have a patient who is diagnosed with non-small cell lung cancer, most of the time what the oncologist would request for or what the oncologist would want in such a patient would be to determine whether the tumor that has been diagnosed has any of these mutations. So either EGFR mutation, ALK mutation, ROS1 mutation, or MET mutation. And the benefit is that if the patient has any of these mutations, then it means the patient can receive a tyrosine kinase inhibitor medication, and that would be targeted towards the tumor. Aside that, for breast cancers, as I mentioned, we have the HER2, and HER2 we all know has a drug that's the Herceptin or trastuzumab, which is directed towards HER2 positive breast cancers. So we also have the PIK3CA mutations who also benefit from targeted therapies, and those who are ERPR positive can benefit from hormonal therapies. For colorectal cancers, if the tumor that is proliferating or is in the colon has or bears the RAS or BRAF mutations, then they can benefit from anti-EGFR treatments. For melanoma, to a target that we would also investigate for is whether there's a BRAF mutation and would benefit from some medication which has been provided. So to summarize, when it comes to some of these mutations, we have the NTRK. So NTRK2 is associated with a lot of the sarcomas and your lung cancers and will benefit from larotrectinib. I'm sure our oncologists are very familiar with these medications. And in tumors which have which are microsatellite high, that is, which have a lot of mutations in their mismatch repair proteins, would benefit from pembrolizumab. And also individuals whose tumors have the BRAF mutation would benefit from dafrafinib and tramitinib, which are medications which are of use in targeted treatments. So commonly, now as I mentioned, we have the PDL1 mutations, and depending on which assay we are using, the patient may benefit from either atezolizumab, which is, I think, Tecentriq Okay, is it Keytruda? It's one of them. So either Keytruda or pembrolizumab. So it's very important that we try to unmask or perform some of these tests so that our patients can benefit from these available treatments. Okay, so what is our role? So basically, our role in MDTs is to ensure that we provide timely, standardized reports which are usable. And also during the meeting, we are to interpret the report findings clearly to team members. And also in the scenario whereby we have to recommend appropriate molecular testing we will do that. And aside that, we also engage in discussions on tumor biology. So basically, the tumor biology is the morphology and the immunohistochemical profile and also the molecular profile. And also, we try to resolve any diagnostic ambiguity which may be on the part of the clinicians if there's any ambiguity in the diagnosis. So basically, in unmasking or discussing the tumor biology, that's where some of these things can come up. Maybe the oncologist may suggest some molecular test or some immunohistochemical test which will help come to a conclusion and make the patient benefit from treatment where applies. So the key point is we are not just diagnosing, but we are also trying to define the treatment path for our patients. Okay, so what are the challenges and the future directions? So mostly the challenges with the molecular profiling is the quantity or the quality of tissue. So most of the time we have challenges where we receive a tissue biopsy and the tissue is very scant, such that by the time we finish our first level, that's our histopathological report, there's very scant to no little tissue to go ahead to perform some of these molecular testing or immunohistochemical testing. So we would advocate that at least when you are presenting or you are giving us tissue for histological diagnosis, you think about some of these tests so that you give us a lot more tissue, which will be beneficial in testing for some of these genetic mutations. Also, there's a challenge with turnaround time. Usually these molecular testing take a while, or they take some time before you are able to completely decode the profile of the tumor. Sometimes may take up to a month before the molecular profile report is ready. So in such scenario, it means that it's going to kind of affect the patient who is undergoing the test. The other two is the cost and the access to testing. So it's, a lot of labs don't really have this resource to provide these testing, and even if they do, the cost is very high to the patient. So that's a limitation or a challenge. So for future directions, we are hoping that with the development of AI and digital pathology, there may be some integration of this whole process such that by the time you receive your report, we have all these things set, and that will make the patient more, or make the report useful for the patient if the report contains all these testing that we are talking about. And also the growing use of liquid biopsy. So liquid biopsies, it means that if it is accessible, may be much simpler to do than to going ahead to biopsy the tumor. So instead of giving us tissue from the tumor, a simple blood sample can help detect some of the cancer cells and also the mutations which will be associated with the tumor. And also methylation profiling. So methylation profiling now has or is gaining ground when it comes to brain tumors. So it helps to accurately diagnose the type of brain tumor that you are dealing with. When it comes to brain tumors, morphologically, or what you are seeing under the microscope to make a diagnosis, it is very challenging because a lot of the tumors look similar. So in the scenario whereby you are having some challenges, this methylation profiling can help come down to the level or to the molecular level to actually tell us what specific type of brain tumor we are dealing with. So over time, we are hoping that we'll be able to introduce some of these testing for our patients who would be suffering from brain tumors. Okay, so to conclude, so synoptic reporting, as we all know, ensures that there's clarity and there's completeness and consistency in our pathology reports that we release for patient care. And we also have to know that molecular profiling is very imperative so that it's enabling personalized treatments for patients whereby the right drug is administered for the right target for the right patient. So in so doing, that is going to improve the outcome of the patient. And also, we are very central to data-driven and also multidisciplinary cancer care. So make good use of your pathologist. Thank you.
Thank you, Ozin, for that wonderful presentation. I believe this advancement is for us to help in the personalization of this care. So, but later on, the questions will come. So let's wait for that. Our next core member of the team is the clinical oncologist. So we'll have a talk on the clinical staging or cancer staging and the risk stratification impact on treatment decision and patient outcomes. That will be given by our clinical oncologist, Dr. Ayabila. Dr. Ayabila, if you are ready, can you give us your...
Good afternoon. So my name is Edwina. I prefer to be called Edwina, actually. But Prof. Mona is allowed to call me Ayaba. All right. So I'm a clinical oncologist with Cape Coast Teaching Hospital. I also practice part-time with Kolibu, the oncology unit in Kolibu as well. So today we are going to take a walk through how cancer is staged, and then we'll also look at the risk stratification and how these things have evolved over time and what it means for our patients as well. Okay. So by the end of this presentation, I hope we'll be able to understand cancer staging and risk stratification. And I also hope we'll be able to review what the traditional and then the emerging tools for these things are. We'll also be able to evaluate how this impacts on our patient treatment. And then we'll look at real-world cases that we are using this in. Cancer staging basically is for us to assess how far the cancer has gone. Is it localized? Is it spreading? Has it moved to another region? So you want to know whether it's a localized disease or it's a local-regional disease or what we call a distant disease as well is present. So we classify cancers into the pre-invasive states and then the invasive states. The pre-invasive means that there is no breakage of the basement membrane. So the disease is said to be an in situ disease. And then when you have an invasive disease, what it means is that you have the bridging of the basement membrane. And the moment you have an invasive disease, the disease could be localized to where it started from, or there could be some spread to the regional drainage of that particular site, or you have distant spread to another organ. So usually you have it spreading to distant organs like the liver, the brain, the bone. But it's very peculiar, so we are able to determine which kind of cancers are likely to go to specific sites as well. So we also look at the invasive diseases, we are able to stage them into 4 groups. We have the stage 1, which is limited to the site from where it is coming from. Stage 2 typically would have some extension into the regional drainage of that area. Stage 3 is a larger disease, but then it's still also having some regional drainage involvement. And then the stage 4 typically is the ones that have spread to distant sites. We stage basically to have a clinical foundation for the treatment management we want to initiate for our patients. Is it that the patient will benefit from a single modality treatment? Do we need to do a multimodality treatment for the patients? So this is basically based on how far the disease has gone. Are we going to do a single modality, multimodality treatment? It also allows us to be able to tell the prognosis of the disease state. So patients who have stage 1 disease tend to have better prognosis. Their 5-year survival is usually up to about 90%. And patients who have stage 4 disease tend to have a lower prognosis. Their 5-year survival is less than 10%, basically. This, however, is changing depending on whether the patient has access to current treatment management that we have available. Again, when we do disease staging, we are able to implement some surveillance strategies. How do we follow up these patients that we've managed? The initial treatment that we've done, how do we follow them up after they are done with their initial treatment? How are we able to pick up any recurrences that might develop? How are we able to pick up any future meds that they might have as well? So it is very important to know the stage of disease so that you can put in the surveillance practices that you want to put in place. Again, with staging, we are able to communicate as scientists. So the world over, if I mention that somebody has colon CA, the patient has stage 1 disease, a surgeon, oncologist, a pathologist in South Africa, in Kenya, in Egypt, should be able to understand what I'm saying. And the person is able to say that, okay, such a patient, this is what we are going to do for the person, because we've standardized what that means for everybody. So the communication is easier for all of us. We have different staging methods. We have the clinical aspect of staging. We also have what we call the radiological aspect of it, and then the pathological aspect of it as well. So we had a surgeon talking, we had a radiologist giving us a lecture as well, and then the pathologist also giving us a lecture. Now, the surgeon typically would help with the clinical aspect of this. The patient has come, you take your history, you do your examination, and your examination and your history taking should be thorough. So that if you do your clinical assessment, for instance, and you talk to a patient, the patient has a breast lump. Patient tells you that I have developed a breast lump. Over the past 2 months, it's become bigger in size. Aside becoming bigger in size, I've noticed that the skin around my breast is looking like the orange peel, or it's becoming ulcerated. Initially, it's giving you an impression of what it is likely to be. And then whilst you're also talking to the patient, then you ask the patient some systemic issues they might have. Are you coughing? Are you having back pain? Are you having difficulty in walking? Do you have any chest pain? Are you having headaches? Are you vomiting? This also points to some things that would let you know that maybe there is a likelihood that the patient has distant metastasis. Or you're able to talk to the patient and say that, look, in your family, do you have anybody who has a history of malignancy? What are the common malignancies that have happened in your family? So that way you are able to pinpoint what the likely issues of your patients are going to be. In the examination as well, you don't just examine and then you leave it as it is. You are not writing the tumor size. You are not writing where it is located in the breast. It's probably in the left breast, but which side of the left breast? Is it in the upper quadrant, lower quadrant, outer or inner quadrant? You need to be able to state all that. And these are very relevant for us because as we are moving on, we are able to assess the patient, assess their response, and use all this information to the benefit of the patients. Now, every primary site you are examining as well, you should be able to examine the regional nodes involved as well. So examine the regional nodes, examine like likely areas of disease spread as well to be able to note what you find. And then when we give treatment, we are able to say that, okay, the patient is having a good response or the response is really not good as at the moment. So the clinical staging is supposed to help you with your initial assessment, and it must be done and done very well as well. With the radiological staging, they help us to further examine the extent of the disease. So we'll do mammogram, X-rays, ultrasound, or CT scans or MRIs, depending on which one is affordable for the patient. So your mammogram will tell you the size, will tell you the location. It will surprise you how mammogram is very beneficial to we, the oncologists, especially the radiation oncologists. So a breast cancer patient has been seen, the patient has a mammogram, patient probably had a wide local excision. In our treatment planning, if we know where the lesion was located and we need to give the patient a boost, based on what the mammogram description is, we are able to localize where it used to be, and then we can give the boost to that place. So it's very relevant to do appropriate radiological examination in all your patients so that we can know the way forward for them. CT scans, MRIs are also very important. You realize that in prostate CA, you can have a patient who has an intermediate risk prostate CA. And then you do the multi-parametric MRI, and you probably picked up a lymph node where you didn't actually expect it to be. So then you change your management or you adapt your management to suit, and then you'll be able to cover all that you need to cover in such a patient as well. So like I said, it's to help you determine the extent of the disease. And then with the pathological methods of doing staging, it's going to help you confirm what the diagnosis is. So the pathologists can use the FNACs that you've done, can take the core biopsies that you've done, your true cut biopsies, and then give us a definite diagnosis and even do further workups on it, like the immunohistochemistry. That also helps direct the treatment that we are going to give to the patient in future. So we have different types of staging. We have the clinical staging. Those who come to MDT will realize that now when you see people presenting, they will probably say, so the patient has a clinical T4B, N2, M0. And if you look at the writing, we've probably written CT with numbers by it and something. That's the clinical staging. And it's based on your clinical assessment, your radiological assessment that I had mentioned earlier on, and then the pathological assessment that was done. And then with the pathological staging, it could be done upfront. So I've seen a patient in the clinic, and I suspect that the patient has a lesion, and the lesion is excised. But we send it to the pathologist who does the assessment and gives me the size of the lesion. If lymph node dissection was done, he's able to comment on all that. So he gives me the staging now. So now that lesion comes back to me, or the pathology report comes back to me, and they have pathological T1, N1 or something. But they can't give me the M, because the M is where I need a radiological staging for. So then I'll do my radiological staging to add my M to it. But the pathological staging, they will give me my lymph nodes and then the tumor extent as well. And sometimes we have patients that will give them some form of treatment before they go for surgical intervention. And that's what we call the neoadjuvant therapy. The neoadjuvant therapy that we give, it could be hormonal, depending on the performance status of the patient and whether the patient is fit for hardcore systemic therapy. Or it could be chemotherapy that we are giving to the patient, or immunotherapy, or sometimes it's a combination of things. In some settings too, we do give neoadjuvant radiotherapy as well. So after we've done that and the surgeon goes in, does their surgery, we give it to the pathologist. When he reports, now you notice instead of having a PT, we have a YP. The Y is an indication that the patient has received some form of neoadjuvant therapy. And then it allows us to assess how well the patient has responded to the treatment. So with the pathological staging now that we get, we want to see whether the patient had a complete pathological response or didn't have a complete pathological response. This is very relevant when it comes to managing the patient. Previously, we would give neoadjuvant chemotherapy. We didn't really care about the pathological complete response, but research has shown that depending on how well you respond to the treatment, it has an impact on your disease-free survival. So we are interested in knowing how well we can actually give you further treatments or give you more treatment for your diagnosis. And then there is the restaging. You have those patients that you probably did your surgery for, they vanished, they came back with a new recurrence, or those that you actually treated, give them everything they needed to have, but then they come back with a recurrence in where the lesion used to be. So you have to restage them as well. Traditionally, we've used what is known as the TNM staging, where the T stands for the tumor size and its local elevation. And then we've used N for the regional lymph nodes involvement, and M implying the distant spread of that disease. This is what has been considered to be the gold standard in most solid tumors. And internationally, everybody accepts it, and we understand what it means when we discuss it. So when I come and tell Dr. Olzinapia that the patient has clinical T1N what, he knows what I mean. When he's reporting back to me and he tells me the patient has a YPT something, I also understand what he means, because it's the gold standard that we are using for solid tumors the world over. And then with gynecological cancers, we have what we call the FIGO staging, which works for them. So we use that one in cervical cancer, in endometrial CAs as well. But even though it's well recognized, it still has some challenges. It doesn't tell me much about tumor biology or its molecular characteristics. So this is changing, because that was the limitation associated with this traditional method. So this has changed over time. And so that's where we now move into what we call risk stratification in cancer. What that does is going to help me understand the aggressiveness of the disease. How aggressive is the disease? What are the chances that patients having this particular disease with these characteristics, what does it mean for the patient in terms of prognosis? How is the patient going to fare in future? What treatment am I supposed to do for the patient? Because sometimes I can tell you that, oh, patient, Mr. So-and-so has a low-risk prostate CA. And then we all go ahead and say that low-risk prostate CA, he has the option of going under active surveillance, or he should go for surgery. But what helps me make that decision without me worrying that in future he's going to recur or he's going to progress very soon? So risk stratification are some of the things that we are using to guide the decision we make in terms of whether our patient's disease that they have is high risk, is intermediate risk, or is a low risk disease. And we can personalize their treatment based on this risk stratification. Different methods for assessing the risks in your patients. We have the clinical and then the pathological assessment. That's the baseline. Every case you see, you have to do your clinical, your pathological assessment. And then now we have advanced imaging. So the radiologist did talk about PET. She did talk about, I think she spoke about PET. Did you talk about the PSMA PET too? No, but we do that now. So in Kolebu, we are doing the PSMA CT for our patients with prostate CA. It's very specific because it's purposely for prostate cancer. So I have a patient who has prostate cancer. I want to see whether it has spread. And I know that whatever results I'm getting is quite specific for it. I mean, it's not 100%, but it's very specific and sensitive for prostate cancer. So I'm comfortable treating my patients appropriately based on my findings. And it also allows me to make a decision where my personalization of the patient treatment means that I'm not going to give the patient treatments they don't need. And I don't also undertreat the patients because I assume they had a low-risk disease. And then there is the molecular bits of the methods. And I love the way the pathologist put it. He said trying to naked the tumor. And it's true, because if you have the gross pathological confirmation of a malignancy, what it means is that, okay, you have adenocarcinoma of the prostate, and so, like, what does it mean? It doesn't mean much, because you can do your usual treatment for the patient, and that is it. Or adenocarcinoma of the lung, after I've given you my systemic therapy of chemotherapy using carbotaxol, what's next? But with the molecular profiling, now what I'm able to do is that I'll give you targeted treatments that are very specific for that tumor. And then the side effects, that even though there are side effects associated with targeted treatment, is more directed towards whichever lesion that you have, and it's milder than giving the person the traditional way of treating them. So with the molecular and genomic profiling, it allows us to look out for the predictive biomarkers. Predictive is that, like, it helps me know which treatment my patient is likely to respond to, whilst the prognostic biomarkers or signatures is like, regardless of whether I treat the patient, when these are present, this is likely the outcome of it. Whether I treat the patient or not, this is how it's going, the disease is going to progress. So I did mention the PSMA PET scan or CT in prostate cancer patients. It allows us to detect very early metastatic disease. If they have any lymph node involvement, you're able to pick it up. If it's outside the pelvis too, you're able to pick all those ones up. Typically, sometimes your normal or conventional imaging will not be able to pick some of these things up. And then with the PET scan, I'm sure one of our arguments will be about we don't have PET scan in Ghana. Well, we are expecting to in Ghana so far. So very soon, you can refer your patients for it. Cost is usually going to be one of the things that would discourage us from writing it. But sometimes when you talk to the patients, they do listen, and they are able to go ahead and have these things done. But this one basically evaluates how metabolically active your tumor is. Is the tumor being metabolically active so that it's picking up whatever you are feeding it whilst you are doing your treatment. And it allows us to do initial assessments, follow-ups on patients who have had treatment, or to just clinically assess a patient who has completed treatment and probably has some complaints that is making you wonder, or you pick up something on a different radiological imaging, and you're not sure whether the disease has spread or it hasn't spread, so you use the PET to assess your patient as well. So let's see where we've used a few of this molecular or genomic risk profiling. In breast cancer, we have the oncotype and then the mama print. Oncotype allows us in patients who are hormone receptor positive. We look at them, use the oncotype gene expression assay to predict whether they are likely to develop some recurrence. So this is for basically hormone receptor positive breast cancers, early hormone receptor positive breast cancers. And when we use Oncotype DX in these patients, it's because it's predicting whether they have a recurrence, high recurrence rates, then we'll know whether we want to give them chemotherapy or not. So it allows me to eliminate chemotherapy in patients who don't need it. But it's only for early breast disease, hormone receptor positive breast disease. Mama print, the gene that it looks out for is much wider, and it also looks out for more molecular subtypes of chemo, so of breast cancer. So instead of hormone receptor positive, now I have the HER2 positives as well, and then HER2 negatives also being patients that I can look out for and determine whether I want to be more aggressive with my treatment. Dicepha and then Prolaris is also one test that we are, there are two different tests actually that we use in prostate CA to determine the risk of recurrence in patients who have had surgery or have had some form of radiotherapy. And then when you use this, you can use it to determine the tumor aggressiveness and then determine whether they need adjuvant treatments or they need you to intervene or leave them alone and then observe them and follow them up as you should. In endometrial CA, the Cancer Genome Atlas project has been able to outline some molecular classification for them. So based on whether, so the patient can have an early disease, very early disease, but some of these molecular classification, if they belong to some particular molecular group, like the TP53 group, regardless of how you've classified it, you need to be aggressive in your treatment with this group of patients because we've realized that these molecular subtypes tend not to do very well as well. And the lung CA, you've heard a lot about the molecular profiling present for them, the EGFR mutation, you do your ALK mutation, ROS1 and others, and then you can use it to determine the targeted treatments they can get. Now, the world is moving towards what we call dynamic risk stratification, and this is very well outlined in what do you call it, in thyroid disease. So it's something that is evolving, but we are still hoping that it would evolve into other cancers and we'll be able to use them for those ones as well. So with dynamic risk stratification, the concept is to move away from this fixed way of looking at patients to a more fluid way of looking at them. So instead of saying you have thyroid disease, you must have surgery, after surgery go and have radioiodine therapy, and that is it. We follow you up, you come to me every 4 months. We are doing more of the fluid approach where we do, after your treatment, we'll reassess you. And then we use markers imaging for that one. And then afterwards, we follow you up. And then if your risk is very high, we'll determine whether you need further intervention or we should just leave you alone. That's what basically the dynamic risk stratification is. So there is the initial assessment, you do your treatment for the patient, and then you assess the response in that patient using your biochemical markers, and then imaging. If you think the risk for recurrence is high, you go ahead and adjust your treatment for the patient, or you adjust the staging for the patient as well. But this is very well utilized in thyroid CA now. So what is the impact of staging and risk stratification on the treatments that we make for our patients? It helps us determine whether our surgical intervention for the patient is going to be extensive or not. Now we are moving towards organ preservation. Have you seen a rectal CA patient before? Patients with low rectal CA. Most of them are avoiding treatment just because of the colostomy that we do for them. They wouldn't even want to come to you. Like the moment they come and we talk about, you have a colostomy, a permanent colostomy done because you have a low rectal CA. Most of them will just vanish from the clinic. They won't even tell you anything. You try to call them and they won't even mind you again because you spoke about something that sounds like a taboo. And it's because of our cultural setting and then sometimes our educational level too. So it makes some of these decisions a bit difficult. Even in the Western world, you have young people avoiding surgeries because of some of the implications that it means on their quality of life. So we want to improve the quality of life of our patients. So stratifying them, staging them helps you to make a better decision for them with regards to the extent of the surgery you can do. Rectal CA now, we have what we call total neoadjuvant therapy, where you can do it and offer or take away the surgery. So if the patient had a very good response, you can preserve their organ for them. If they didn't have a very good response, you let them be aware, then you go ahead and do the surgery. So at least the patient knows that you give them a good shot at life and improving their quality of life for them. Again, it also impacts the adjuvant therapy that you can give. So if I had surgery, or if I had surgery for a malignancy, am I going to benefit from radiotherapy? Am I going to benefit from further chemotherapy? Or am I going to benefit from you giving me radiotherapy, further chemotherapy, and some form of hormonal treatment? We need to know all this, and staging risk stratification helps us to do all that. Again, it also allows us to implement the surveillance that we want to do for the patients. This patient is a low-risk patient. How often do I want this particular patient to come to the hospital? And if I want you to come to the hospital very often, what are the specific things I want you to do? Because you need to look at the money involved in following up your patients. The imaging you are going to do, how expensive is it? The biochemical markers that you are going to do, how expensive is it? So we need to know all this so that we can implement a better follow-up plan for our patients. Okay, so we've looked at, I've mentioned all the clinical applications already. We've looked at prostates, where we are using the PSMA PETs in this group of patients. Breast cancer, where I mentioned the oncotype and then the mama print as well. And then with the endometrial CF, I've already mentioned the molecular subtypes and that we do for them and how it impacts on the treatments we give to this group of patients. So look at how we've integrated advanced staging and risk stratification in these particular cancer types. Look at prostate cancer. Now we do genomic classifiers, then the PSMA PET or CT, whichever you have available. And we've realized that it has improved survival in patients, like all the patients that we are using this for. Those who don't need further treatment, you don't do the further treatment for them. Those who need more intensified treatment, you do it for them because you want to reduce the risks of disease progression in them. In endometrial CA, the FIGO staging with the molecular classification also means that patients now have a better survival because you are reducing the rate of recurrence in this group of patients. And then with breast, we are doing molecular subtyping. Molecular subtyping is also helping us determine which drugs they will benefit from and then which drugs they don't need to have. Can you imagine the number of patients who have had hormonal therapy in the past just because they had breast cancer? And our thinking then was that, well, the estrogen was involved in it, so let's put them all on hormonal therapy. But with the molecular subtypes, we know those who would benefit from hormonal therapy, we know those who wouldn't benefit from it, and you needed to do more of other systemic therapies for them. And then with thyroid, we are now doing more of the dynamic race stratification in this group of patients. So there are challenges with implementing some of these newer ways of looking at things. The validation and standardization is not the same the world over. So we need to bring it apart for everybody. So it's still something that is evolving. We are still working on it. So we've not come up to a conclusion and said like the way the TNM is, where we say T is this, N is this, M is this. So until we get there, we can't generalize it for everybody. So the world is moving towards that. And maybe this is the time that we need to fight for Africa to be involved in a lot of clinical trials so that when this thing is standardized, we can be able to generalize it to our settings as well. And then combining the molecular and then the clinical imaging into data that can unify this model is also presenting a lot of technical and challenges when it comes to interpreting it. Because, as I said, we've all not come to a conclusion on a common language that we can use for some of these things, or some of the common parameters we can use for all of them. If I'm doing my research, I'm using my own parameters. If Mervyn is doing his research, he's using his own parameters because we feel that's what is working. So until we all come together as like the world and come to a conclusion on what works for everybody, it's difficult integrating some of this. But for us, our challenge has always been with resources. Resources in terms of access to equipment, access to having the newer machines and things that are reading some of these new developments. We are having challenges with that. And not just that, our patients finance their care out of pocket. Insurance covers virtually nothing. Like it covers something, but it's also not a lot when it comes to looking at how the world has evolved in terms of care. So we have our resource limitation in terms of the system and also in terms of our personal financing for some of these things. So that's what is contributing to our delay in implementing it. AI has evolved so much. The world over, people are putting up data that is allowing AI to be used in pathology, to be used in diagnosis and stuff. But we haven't gotten there yet because we still haven't. I don't even think as a nation it is part of our policy making to look at AI implementation in some of these things. And then when culturally, a lot of things will also stop most people from participating in clinical trials. So how are you even going to implement it if you actively want to be part of it? People already think that when you say they should be part of clinical trials, you are using them as a guinea pig. But research shows that patients who take part in clinical trials actually do much better than their counterparts who are not involved in clinical trials. In clinical trials, we select the very best out of you. You get the very best of care, the very best of follow-ups. The way we follow you up is totally different from if you are not in clinical trial. So I'm sure if I was a patient, I would definitely enroll in a clinical trial if that opportunity comes. Okay. So all of us have mentioned that the future direction indeed involves we using artificial intelligence in all that we do. Whether we like it or not, you can have your perception about artificial intelligence, but it's the way to go now. And we need to be able to use this machine learning algorithms, integrate it in all our data sources. So the pathology data source, our clinical care data source, our radiologist data source, we need to be able to integrate AI in there so that we can get the very best of outcome. Because as we always say in computer language, garbage in, garbage out. So the more data we feed, more accurate data we feed into some of these systems, it makes things easier. And one of my arguments is that I think Africa will benefit more from AI integrated stuff because our human resource is lower, our infrastructure is also lower. So you need something that makes your turnaround time faster. And AI has that capability of doing it. So it's about time we probably consider doing something like that. And then the validation is still something we need to work on, and standardization is also something that we need to work on. We will keep on fighting for global access, but the world will not wait for Africa. So when you look at the FIGO staging, before it was just about using your clinical examination and then some basic radiological examination to stage your patients. But the Western world realized that it wasn't helping their patients. So then now you're allowed to do more advanced staging. But they still made room for us. So maybe we need to also develop ourselves and then move in to join the global level of doing things. And the world will not come and do it for us until we do it for ourselves. So we want to be part of the broader implementation of some of these things, but Africa needs to be able to start pushing itself towards that. So in summary, the world is basically moving away from the traditional way of taking care of patients, where we had a one-size-fits-all for every patient. You come, you have breast cancer, so it's surgery, chemotherapy, radiation. Basically, that was it. Now we are moving away from that. We are doing more of what we call precision oncology. With precision oncology, you tailor the patient's need for them. And you can only do that if you're able to stage them and re-stratify them appropriately. Again, the outcomes have been shown to be better with this approach. You are giving them what they need when they need it, not because it is available. You are giving it to them because this is what they need, and this is the time they need it. So you give it to them and improve their outcome, reduce the side effects associated with some of these treatments that we give, and improve the patient's quality of life and quantity of life. So we don't want to let you live long, improve your survival, and then that survival that you have is a very bad survival because you have very bad side effects that is terrible to deal with. And then going by this approach also allows us to be part of a lot of collaborative stuff. So if we are doing research, we are staging our patients appropriately, and there's some research going on, we can easily be part of it because we can say that, oh, we were able to do these tumor markers for our patients, we were able to do this genetic profiling for our patients. But because we are not doing some of these things, when the opportunity comes, it's difficult for us to be part of this collaboration. So it allows us to be part of a greater collaboration, and I think it's about time we as a continent, and maybe CCTH can decide to be the oncology hub for Africa, where we start moving towards some of these things. My references, and thank you.
For me, the take home is CCTH being the oncology hub for research. I mean, that is beautiful. Yes. Eventually we'll get there. So we have a few more presentations, but I think the snack break has taken a toll on some of us. Can we stand up and shake it off small? Yes, we also have some breast questionnaire we are going to share right now, so that as you are shaking it off, you are thinking of filling that questionnaire for us. So just a few minutes to shake it off. The calories you took right now.
This one is forward and back.
we can come back to the hall. Oh. Those shaking it out there. We can come back to the hall. Hello, those outside, can you come in so that we go on to the next presentation? Magdalene. We are not It's not stating pathology in it. So the next presenter is going to talk about an important part of the cancer management, which is patient navigating the MDT cancer care. Our patients really struggle to really find out how their management is going, and we know how important our oncology nurses are in terms of navigating this treacherous treatment that is given to them. So in our midst, we have Magdalene Danyono. I've crucified your name. So I would just mention the Magdalene and leave the rest. So Auntie Magdalene, if you are ready, come and give us your presentation.
Oh, Dr. Fori, you crucified my name. Good afternoon. My name is Magdalene Ifia Denayo, oncology nurse at Cape Coast Teaching Hospital. I don't know where you Denayo. Yeah, so this afternoon I'm going to present on the importance of patient navigation in multidisciplinary cancer care, guiding patients through cancer care. Okay. So my objectives are to define patient navigation in multidisciplinary context and its importance, describe the role and the responsibility of a patient navigator, and also describe collaboration within the multidisciplinary team and impact of patient navigation. So this is my presentation outline. So understanding patient navigation, what is it? So patient navigation is a patient-centered healthcare service model where, okay, thank you. Patient navigation is a patient-centered healthcare service model where trained personnel help guide patients through complex healthcare systems, addressing their barriers to timely and quality care. And this model was introduced by one Dr. Harold Freeman in 1990. at Harlem Hospital. His goal was to reduce disparities among low-income and minority populations. So, patient navigation, the common roles that they can play as nurse navigation is one, to give clinical guidance to the patient as well as care coordination. And the lay navigators are people in the community. They could be public health personnel, and they are trained to navigate patients as we send them back to the community. And they also give peer support, like introducing the cancer patient to their colleagues, those other people with cancers. And also, they also do community access and also give cultural, cultural bridges, like they bridge the cultural barriers, or they talk about the cultural barriers, extending it to the MDT, to the multidisciplinary team, so that they will know what the patients, the barriers for the patient, in order to use that one to take care or give or do their treatment options. And we also have the social worker as a navigator. The social worker also takes care of psychosocial issues and also makes sure patient gets the necessary resources for their treatment. And also, they also introduce or take care of their mental health. So what is multidisciplinary team in cancer care? For this one, Dr. Ajman, my boss, has already touched on it, telling us their goals and the challenges that they face, so I'll skip. So I think he also explained this one. Okay, so why patient navigation is essential in MDTK? So patient navigation is essential because it reduces care delays and missed appointments. Sometimes a patient will do core biopsy, and it will take time for the patient to get the core biopsy report. But this time around, the patient navigator do follow-ups to make sure that the patients, they get their reports on time, so that they will not be falling into the cracks created by the health system. It also improves communication between MDT members. All the time, everybody is all the time, MDT members, they have information that all of them know, so that they will use that to cater for the patients. And they also do personalized care. They also do personalized care journeys, because no patient is the same like the other patients. And everybody is different, so they treat them individually. And patient navigation also helps foster trust and better patient engagement. So as you are with the patient develop you create some interpersonal relationship with the patient. And because of that, they trust you to the extent that they are able to tell you their problems, and it helps with their engagement in their care. So for patient navigation across the care continuum, so patient navigation starts from the point of diagnosis, or from the point of identification through to survivorship and end of life care. So when you are screened and maybe they identify an abnormal lump in the breast, the navigator will help you to come and do core biopsy. The navigation will follow up for abnormal results, and then the diagnosis. So when at the diagnosis phase, they also help schedule biopsies and explain diagnosis to the patient. though the first point of explanation to the diagnosis will come from their doctors, but when they come to you, it's like they don't even know everything. Sometimes they don't know anything. Sometimes you talk to them and it's like, oh, the doctor didn't tell me anything. And I tell you, if you don't tell me what the doctor says, then I'll send you back to your doctor. So what we do is to make sure that we reinforce what the doctor tells the patient and make sure that they are so when it comes to the treatment phase, the patient navigator aligns with MDT to ensure patient understands and adheres to their treatment plans. But for survivorship and end-of-life care, the patient navigator will plan transition. Sometimes we get patients, maybe at the beginning they will say, oh, their treatment is for cure. Then at a point in time, like they will get metastatic disease. So you re-explain the whole thing to the patient to make sure that the patient understands. And the end-of-life care, most of the time we refer to palliative care or the family medicine. They are responsible taking care of end-of-life issues. So we coordinate, we get to them and make sure patients get the needed support. So these are some of the roles and responsibilities of the patient navigator. So we see the patient navigator as a care coordinator. And we see the patient navigator as a care coordinator. And the patient navigator ensures seamless communication among MDT members. And then they also help organize and track patients' appointments, referrals, and diagnostics, and treatment across the care continuum. We ensure communication because most of the time, some of these patients, I don't know whether they are shy or not, they are not willing to open up to their doctors. But because we are always with them, they come, they will tell you, oh, Auntie Ness, these are some of the problems that I'm facing. And because of the, when the patients voice out certain things, you have to be the advocate for the patient to communicate with the patient's physician or oncologist, clinical oncologist or radio oncologist, for him to know that, oh, this is what is happening. So maybe at MDT meeting, they may decide and come to a conclusion as to what to do for the patient. So the patient navigator also helps organize and track appointments, referrals, and all that. So with the tracking of patients, some of the patients, we lose them in between, like from diagnosis or maybe after core biopsy, they will not come again. After diagnosis, they get scared, they go, they don't come again. But initially, we didn't have anybody doing patient navigation, but now we have patient navigators, and they are doing all this. When you get your core biopsy done, they will follow you out, they will bring you back, they will let you know or see the reason why you have to be present to do the treatment or whatever they ask you to do, your clinicians ask you to do. Then they also facilitate implementation of MDT care plan. So at MDT, we don't just go and sit down and listen to what they say. What we do is that we make sure that whatever plans make for the patient is immediately started to make sure that there are no delays for better outcomes. Yeah. So let's see the patient, the navigator as an educator and a supporter. In education, they make sure they educate patients about the diagnosis and staging of their condition, though they will be told from the beginning by their clinicians. by their doctors. But when they come, as I've mentioned already, when they come, it's, I don't know, maybe it's because of the diagnosis or whatever it is. It's like they are confused. You ask them and it's like they don't know anything at all. So you have to go all over and make sure that you educate them. This is what you have. You have breast cancer. It's early stage. It's gone to other place. This is what we can do for you. For early stage, we can cure. For metastatic disease, what we can do is to manage your condition for you. And some of them will ask you, manage the cancer. As soon as you are diagnosed with cancer, then it's a death sentence. No, it's not like that. It's like me having this one, yours is turned into chronic disease. Me having hypertension, I have to take medicine to the end of my life. So this is how we go about making them understand and making sure that they see the reason for them to do their treatment. So I think I've mentioned that on treatment options and potential side effects. So it's also helped, the patient navigators also help patients understand complex medical information. The things that we tell them. If patients come and I say, oh, you have a metastatic disease, it's like, hey, I don't get this, I don't understand. What's the meaning? So we have to explain all the medical jargons to the patients and make sure they understand and understand why they should take their treatment. But if that education or support fails, we make sure that we send them to the clinical psychologist. The clinical psychologist is the expert in this, and the clinical psychologist takes it up from there. So we also have barriers. The patient navigators also identify barriers and make sure they reduce these barriers. Barriers like logistics, financial, culture, and emotional barriers. And sometimes it's language. I'll use the language barrier because we get patients coming from Ivory Coast and all that. These patients, when they come, they speak French and we don't understand French. So how do we communicate with them? It's very good. We don't have so my people are laughing at me. We don't have somebody who can translate this, and we can't just go and take any lay person. We will be just exposing our, how do I put it, like confidentiality issues. It's like you are selling the patient to somebody. So I don't know if boss will help us with a translator. HOD, he understands French. And the other fine. So apart from that, they also assist with transportation and lodging issues. Sometimes it's very difficult for patients even to pay their transportation back. But we find a way around it, get some people who can support them small so that they will pay their transportation to the facility for their treatment. Those without insurance, we make sure that they do their insurance, prepare their insurance, and we give them some financial counseling. We counsel them on their finances because sometimes it's money, but sometimes when they come, some other time somebody was asking me why we should tell the patient about all the treatment regimens, like having surgery, radiation, everything. Why should I mention that the patient will go out? No, some of us, we don't have the money. So what we do is that when we get one city, we put it somewhere. If we know that we are going to do surgery, if we know that we are going to do radiation, we'll put the money somewhere, small. By the time we finish with neoadjuvant chemotherapy, we may have something small to start with radiation. And the person was angry because I gave that education to my patient. So, as nurse navigators, we are also the advocate for our patients. Everything concerning patient's treatment, concerning the patient, him or herself, everything, we have to talk about it. We have to channel it to the right places. For them to be able to, like, when you do that, it gives them the confidence, like, oh, I know somebody supports me. Even if I'm not able to come, the person will be able to, like, do something for me so that I will come with their doctors, surgeons, radio oncologists, everybody. We are the advocates. And it's our responsibility to track and follow them. Track them to avoid falling into those small cracks that we have within the healthcare system. And we do follow-ups. And you won't believe what this follow-up is doing. It's doing magic, because we have a lot of patients right now in Cape Coast. Very soon I'll give you the statistics, and you'll know. So we track, and as I said, they monitor patients' progress through the treatment and survivorship. It's not like, oh, we've given you treatment, so you have to take treatment. Maybe they ask you to take AC times 6. You've taken about 3, but still you can see that the tumor is still there. So the patient needs to be reassessed, and maybe the treatment changed, or yes, whatever. So and so it's the responsibility of the patient navigator also to ensure patient attends follow-up appointment and completes recommended treatment. Some of the patients, they finish their maybe adjuvant treatment, they do their radiation, but they have to come for follow-up, because if they don't come, they might recur and nobody will know. So we make sure this, so we do phone follow-up. And so right now, how do I put it? Right now, I'm asking my boss if, I'm asking my boss, because this call that we've been making for about 6 years now, nobody is giving us anything, any airtime or, so. And it's the responsibility of the patient navigator to track outcomes and provide data for MDT. If we are like presenting on patients without knowing how they are doing or how they are responding to treatment, then we are not doing anything. So as I said, very soon I'll give you what, like from 2020 to 2024, the data that we have on patient navigation, a multidisciplinary team meetings and their clinics. Also, it's the responsibility of the patient navigator to facilitate timely access to care. As I said, it reduces delays in diagnosis, treatment initiation, and specialist consultation. It also helps prioritize urgent cases identified by the MDT. So when these cases are, like when these cases are discussed at the MDT, some of them you see that they cannot wait. Sometimes if they are IAC and other things come, they've been discussed, but maybe we are waiting for IAC, and it comes late and our bosses are not here. We do phone, we call our bosses, talk to them. This patient cannot wait. So they may ask us to start, and maybe the next clinic, the patient will come to the clinic. So it's also the responsibility of the patient navigator to support survivorship and end-of-life care by assisting with sponsorship care planning, survivorship care planning, example like lifestyle support or recurrence. Let's take a breast cancer patient, for example. The breast cancer patient might have a mastectomy done, and some of them, they feel so shy that they have one of their breasts off. So what we do is to support them, maybe with some prosthesis and other things to make sure that, oh, when they put it there, oh, when I go out, nobody will see that I've done mastectomy. And also, they also come, we monitor them for recurrence of their disease. That is why we ask them to come for follow-ups. When they come, they are examined, and when anything or any new lesion is found, they are asked to go do biopsy again for them to see what is really happening over there. And it's the responsibility of the patient navigator to coordinate palliative and hospice care when needed. Yeah, because we get a lot of metastatic breast cancer patients, those who will need, so we hand them or coordinate their affairs, we hand them over to family medicine or palliative care units. But we have palliative care units at 668. I hope we'll have, it's coming, okay. So how patient navigation collaborates with MDT? So patient navigation, there is coordination of MDT meetings. For these meetings, the nurse navigator or the patient navigator will be the one to coordinate the MDT meetings by setting up the meetings, making sure all the needed all the needed people, or doctors, oncologists, pathologists, everybody is present. And they also help prepare cases and make sure contribute to non-clinical insights. Non-clinical insights because some of these patients, as I said, they're rather confined in the nurse navigator than their doctors. And because of that, we need to take all this information from them and make sure that we share it at the MDT to make sure their clinicians with this barrier, their clinicians will be able to give them a better treatment option. So they also communicate the bridge between patient and clinician. That is what I've already, I think, spoken about. We track, there is tracking and follow up, like I've mentioned about. We track and follow because the clinician or the doctors cannot do tracking and follow ups. It's done by the patient navigator and updates given to MDT. And patient navigators also give cultural and emotional support. They are advocates for patients facing cultural or language barriers. Impact of patient navigation. Patient navigation has enhanced patient outcomes. Right now, if I tell you the number of patients we are seeing right now, you will be surprised. We have a lot. Since 2020 to 2020, I think we have about 75 patient presentations, and as compared to the other years, it's increased. Then we have, there is increased patient satisfaction and engagement. Somebody will come and tell you, oh, Auntie Mad, or oh, Sister Doris, in fact, the way you portray us here, we are so like, okay with it. It makes us happy. Like when we go away, you want to always come back. So another impact is on the healthcare system benefit. Right now, because of patient navigation, patients are able to go through their treatment right from point of diagnosis to follow-ups. They are able to assess all the health. There are no barriers right now. If there is any barrier, I don't know of that, because we are always on the doctors and making sure. And patient navigation has really improved care coordination. All although patient navigation is having all this impact, but we still have some barriers that prevent us from doing the work successfully. Barriers, communication barriers. We have low role clarity and overlap. When the patient comes, the patient doesn't know who is who. If Dr. Ajiman, maybe Dr. Ajiman is about Dr. Ajiman is saying this, Auntie Mag is saying this, Sister Gifty is saying that. Like, they don't even understand anything. It's like they don't know who to report to. I think we have to see about that and know our roles and the part that we play, so that we will not be into another person's. So if you can remember, I said that when the patient comes, I will assess the level of the patient's knowledge about what he knows about his condition. But if he says, oh, the doctor didn't tell me anything, then what should I do? You have to go back to your doctor. For me, I would just reinforce to make sure that you understand everything that they said to you. If it's in English and you don't understand, I will just go back to the simple language, like whatever your language, unless maybe I cannot speak that language. At least I can speak Tree, I can speak Fante, I can speak Ewe in English. No, French, that one, I don't want to go there. Mm-hmm. So, and we also have information sharing and documentation. Please, for this one there, the surgeons, are you here? Or everybody is gone. Please forgive me, but I want to say this. Doctor, I want to say this. Documentation is very important because after an MDT meeting, apart from what we write as patient navigators, they don't document on the LEMSO. Only a few of them do the documentation. And so it's also our problem. And we also have patients' complexities and diverse needs. Some of these patients, they have so many comorbidities that by the time we finish their treatment, and it's like, if treatment is supposed to take about 7 months, it takes about 1 year. Because if they have diabetes, hypertension, and all that, and it's not controlled, you have to be sending them to the internal medicine depart for them to be seen and reviewed. Sometimes it takes about a month or two, and it's like the treatment is, that one too is a problem for us. So evidence-based benefits that patient navigation brings about timeliness, and the outcomes in patient navigation is increased treatment completion. Right now, people complete their treatment, especially in the underserved population. Right now, we have people coming from the remote areas of central region. And because of the way we communicate with them, even if they don't have money, they'll try to find the money and come to do the treatment. And because of that, there is patient satisfaction. They are happy. They are happy with their treatment, and they are happy with the outcomes of their treatment. And there is also cost efficiency, because some of these patients, some of these patients, they usually come to the ER and they come for readmission and all that. But with patient navigation, everything is changed, because from time to time we'll be doing phone follow-ups. Oh, Auntie Mark, this is what is happening to me. Sister Gifty, this is what is happening to me. Oh, go to the nearest hospital and let me talk with the physician there as to what to expect, because patient is on chemotherapy. So the patient will go there. So readmission and emergency visits are, so these are the benefits according to research. This one is in the US. We'll talk about Ghana. Patient navigation at CCTH. Okay, so when patient navigation started on officially in August 2020, when the oncology unit was commissioned in the year 2020, we were doing everything. It wasn't for just breast cancer patients. Every patient was on board. You have to follow the patient, make sure diagnosis, the patient understand diagnosis, everything to follow up. We were doing it until in March 2023, when Embrace Society, in collaboration with Roche Pharmaceuticals, piloted a 1-year patient navigation program. Then we started, even that one, like I said, for just breast cancer. But it wasn't bad. We used that opportunity to navigate other patients as well along the breast cancer patients. Currently, we have 2 strong nurse navigators. They've been trained and they are going to support the multidisciplinary team with all their might. Do like this and let me see. Yeah. So, Madam, Sister Doris, Morgan, and Sister Rosemond. Oh, so please just wave so that everybody will know that you are the patient navigator for CCT. Hey, I'm coming the morning. I will reach, don't worry, I will come. So like I said, this one is here. So let me, it wasn't part of it, I just remember. So, as I said, that navigation is really doing wonders. For our case presentation over the 4 years, in 2021, our able doctors presented 263 patients. Then in 2022, we had 279. 2023, we had 237 presentations. Then 2024, we had 326 presentations. For clinics, in 2021, we had 183 patients, both referrals from other places and our own patients coming for follow-ups and chemo reviews. And out of this, we had 75 new cases and 108 old cases. I just want you to have a look at something. The way the old cases were coming shows that follow-up is being very effective. So in 2022, we had 200 patients coming to the clinic. Out of this one, new patients were 66 and old were 134. 2023, we had 320, I hope you are following, 320 patients. New was 51 and old 269. Then in 2024, we had 427 patients coming to the OPD, 37 new cases and 390 old cases. Look at the way patient navigation is doing wonders, supporting MDT. So patient navigation is a cornerstone of high-quality MDT cancer care, and it improves timeliness, coordination, outcomes, and patient satisfaction. It also have integration of challenges, but so there is a way out. We still exist, we have challenges, but it's integration challenges exist, but are surmountable. That is, we can always go through it. So there is strategic investment in navigation, which is equal to better care and equity. Thank you.
Thank you very much. Auntie Magdalene has done wonderfully well. Her presentation, she lets me out. I've been doing navigation since since I became a specialist in 68. Exactly. So you have to acknowledge me. And and Dr. Grant has been navigating for a long time. So you have to acknowledge us. We were not trained, but we know the work. So acknowledge us too. Our doctor navigator. Top navigators. So you see, the new navigators came on board just recently. We have been there before they came. So try and also acknowledge us. So you actually have 4. 2 trained, 2 not trained. I get it. So that we can. Thank you very much. And I'll give you this scenario, this language barrier. I was passing a percutaneous nephrostomy for an Ivorian. Ah, God. My new and I could say. I struggled, and I really did struggle. But so this language issue is a problem. I was wishing I could have taken my French seriously in school, but at that time. Yeah, so we have some few minutes before lunch. We'll take the last presenter. That is Dr. Jantechi. He is going to give us the role of radiation therapy and systemic therapy in cancer management. Let's give it out for him.
Good afternoon. Can we give another round of applause to our oncology nurses? They've been instrumental in the setup of oncology care in Cape Coast. We couldn't have done it without them. And I know we have to pay them extra allowances, but we also deserve allowances for the calls around 9 p.m. in the middle of the night, and our nurses will be calling us. But another round of applause for them, please. Okay, so I'll be presenting on the role of radiotherapy and chemotherapy in cancer care, and I'll end with some data from CCTH. I try to be as brief as possible. We are going into the, pardon me for my choice of words, but the weird area where most clinicians don't understand what radiotherapy entails and what chemotherapy really entails. As part of my objectives, basically, I'll just be answering questions. That's how I plan to deliver this presentation. So what is radiotherapy? Basically, radiotherapy is also called radiation therapy, and it's a type of cancer treatment that employs the use of beams of intense energy to kill cells. We call them ionizing radiations. Now, the radiations you cannot see them with your eye. With the help of radiation, we have the light, and therefore we can see everything that is happening here. We can watch TV, we can use our phones, we can use Wi-Fi. These are non-ionizing radiations, and usually they belong to the visible light spectrum. That enables us to visualize things. Their energies are very low. They do not cause that much harm to the body. And over the years, research has shown that there was a study that actually looked at people who used their phones, kept their phones close to them overnight for a number of months to see whether that was going to increase the risk of developing brain tumors and other cancers. But we realized that that wasn't true because they are non-ionizing radiations. So you using your phone or using the microwave does not cause cancer. We are using ionizing radiations, and these are high energy radiations, and they cause damage to tissue at the molecular level, at the atomic and subatomic levels. So they deposit energy based on the principle of energy conservation. Remember, energy cannot be manufactured, it can just be transferred from one point to another. And the energy is deposited into the atom. It causes ejection of electrons, resulting in breakage of bonds, and then from there, it results in biological effects that we see, and that's how come we're able to use it to treat cancer. So basically, all radiation belongs to the electromagnetic spectrum, and as you move in that direction, you have more energy, okay? And these cause damage to the body, so those are ionizing radiations. X-ray is an ionizing radiation, but the energy is lower, way lower. I call it peanuts compared to what I use for treatment. How is it delivered? Before I go into that, there are different types of radiations, specifically ionizing radiations. We have the alpha, beta, gamma, X-ray, neutrons, and neutrinos. Nobody wants to be exposed to neutrinos. You don't want to be exposed to neutrinos. It will cause damage to you. And therefore, our astronauts who go out of the world even are protected against neutrinos. It's one of the things that they are really worried about. Neutrons, the same thing, and that's why some nuclear facilities are found underwater because water can stop it. X-rays are used in diagnostic imaging, and that can penetrate the body and can be stopped by lead. Gamma rays are also used for treatment. That's what we use for treatment, as well as photons. Beta and alpha radiations are all used for treatment, but their penetrability, alpha radiations, they have a very short range. I'll talk about it as we go along. Beta similar, but gamma goes further. X-rays also go further. Radiation is grouped into two, internal and external radiation. In terms of internal radiation, we have what we call brachytherapy, and also radionuclide. That's the use of radiopharmaceuticals, mainly in diagnosis and also in treatment. And then for external, we have external beam radiation. Basically, the difference between the two is that for the external, the radiation is coming from outside into the body. So the radiation source is outside the body, and it comes into the body. For internal, we place the radioactive element or seed directly into the body. So let's go a bit deeper into brachytherapy for internal radiation. It's a procedure used to treat certain types of cancer. It depends on the type of cancer you are treating. We can use it for some esophageal cancers. We can use it for prostate cancer, depending on the risk stratification, which Dr. Ayabila spoke about. Basically, it involves the placement of radioactive elements directly into the source, directly into the tumor, okay? And some are temporary, some are permanent. In brachytherapy for prostate cancer, for instance, we use what we call the seeds, radioactive seeds, and then we place them directly into the prostate. It's low-dose radiation therapy, it's permanent, and it radiates the prostate over a period of time. Half-life of, depending on which element you are using, which in Ghana we use iodine-125, and that's has a half-life of about 3 months. It involves, so there's also another, so these are capsules, tiny, tiny capsules. I'll show you a picture of it. And these are placed directly under ultrasound guidance into the prostate directly. We also have the temporary ones for cervical cancer where we place let me say, just a metal, okay, which we pass the radiation through to radiate the cervical area. So these go directly to where the tumor is without passing through external structures. So the image on the left is brachytherapy for prostate cancer, and that's your ultrasound probe. Using the ultrasound probe, we're able to determine where to position the seeds. And there's a lot of calculations that are done. This currently can be done in Ghana at the Kolebu Teaching Hospital. In fact, just I think on Wednesday, a group of patients underwent it in urology. Yeah. The image on the right also is brachytherapy for cervical cancer. The metal you see in there, that's what we call the tandem. These two are called the ovoids. They are placed in there and then connected to a radioactive source. That's the cobalt-60. It delivers radiation through it, and just this area is radiated. So we're able to spare all these tissues. So the advantage of internal radiation is that you're able to spare surrounding tissues as compared to external beam radiation, which comes from outside in. In terms of radionuclide use, there's a diagnostic aspect and then the treatment aspect. Dr. Inti spoke about PET scans, spoke about bone scans. This is where radionuclide comes in. They use radioactive substances that are injected into the body. Some are given orally, depending on what you are using it for. And they emit alpha or beta radiations. Remember, the picture I showed you, alpha radiation is very short. If I give it directly into the body, it's not going to go out. Beta can penetrate the body, it goes a bit, the distance is a bit farther. So some of them emit alpha, some of them emit beta radiation, and we use it to highlight areas of cancer. Uptake depends on the type of cancer you're dealing with. The type of substance used also determines the type of uptake. And they are very specific. So in previous submissions, you've heard about PSMA SPECT, PSMA PET. The PSMA SPECT, basically, we are targeting the prostate-specific antigen on prostate cells. So wherever the cancer cells are, they have the prostate-specific antigen. We target them with these radioactive substances, and they are uptake by the cell. So after after it undergoes uptake, then an imaging is done to see where and where they are located. These images are then fused with either CT scan or MRI, giving rise to a PET MRI, PET CT scan. Other images include bone scan, where we use technetium-99 technetium-99 for that. We have a PSMA SPECT CT, which the center in Kolebu has, and we do SPECT CT. PET CT and MRI, currently there's a setup in Sweden Ghana Medical, but it's not yet functional. There are still some things that they are trying to do. So PET will soon be available in Ghana. The machine is already in the country. And now we have radionuclide heart scan. This is not necessarily for oncological purposes. Okay, this can also be for diagnostic, for surveillance, where it's more sensitive than your echo for picking up ejection fractions, yeah. And the disparity, inter-observer differences is very low. It's much better compared to your echo when you want to look at ejection fraction. However, there are cost implications. Also, this can be done at the Kolebu Teaching Hospital in the nuclear medicine department of the center. And we also use them in sentinel node biopsy. Prof. Mason spoke about this, where we inject these radioactive elements into the area of the tumor, and then we look at the first echelon of nodes, which picks them up using a Geiger-Müller counter intra-op, and then we dissect those nodes. This helps to limit surgery, and also promotes organ preservation, preventing lymphedema associated with extensive nodal dissection. If these nodes are positive, then the probability of the second echelon and third echelon being positive is high, and therefore you require further treatment. If they are negative, then you still know that it's still a very local disease. I'll take you to some of the images from the Kolebu Teaching Hospital. This is a technetium-99 bone scan of a 63-year-old patient who came in complaining of non-specific bone pain. And therefore, we decided to do a bone scan using technetium-99. And there was multiple uptake at various places. All the dark areas you're seeing, the dark areas, you can see this side is darker than the rest. These are all areas of uptake and METs. But I need to caution you here. Even though it's picking up sites of METs, it can miss, because this picks up only blastic lesions. It doesn't pick up lytic lesions. So osteolytic lesions can be missed on bone scans using technetium-99. And therefore, if you're treating a patient who comes in with pain, you are suspecting bone METs, but the bone scan comes back negative, it does not rule out METs. You would want to do other imaging. Okay. This is a SPECT CT scan also from Kolebu. The patient presented with bone pain. So this is combined with a CT scan. So the SPECT is combined with a CT scan to produce a SPECT CT. Here, all the areas, you can see this hot area, those are areas of uptake. Okay, and this shows areas of metastatic deposits. But I need to caution you, there being an uptake, especially on a bone scan, technetium-99 bone scan, does not necessarily mean that it's met. It can be degenerative disease. It can be inflammation. Basically, the uptake is higher in bone. When there's bone remodeling, there's increased activity and there'll be higher uptake. And therefore, history is very important when you are requesting for these images. You just don't write breast cancer, bone scan, or prostate cancer, bone scan. History is key. It will help the nuclear physician to really pay attention to certain areas and interpret some of the uptakes, okay? Some uptakes are so clear that he can easily tell you that this is a metastatic disease. Also, when you request for a bone scan, let's say one of the requests I saw was suspected case of cancer, and therefore they've requested for an imaging using a bone scan or a PET scan. It does not histologically diagnose a cancer. It just shows areas of increased uptake. Some of these areas may be inflammatory, or they may be a cancer, but the history is key when you are requesting for these images. There's a FDG PET scan. This is for a prostate cancer patient. The one on the right is for prostate cancer, and you can see for breast cancer, and you can see multiple uptakes. Similar to the SPECT, okay? But the advantage this has over bone scan is that it can pick up both blastic and lytic lesions, all right? Also for treatment, in terms of treatment, when we are using radionuclides, this is all internal radiation. They are used mainly to help control pain and also to control tumor. So we have lutetium, we have so many of them, but the one that we've done in Ghana at oncology by the nuclear physicians was lutetium for prostate cancer for bone mets. But before you get to this stage, you would have exhausted a lot of treatments before you start actually thinking of using a radionuclide for treatment. Currently, it's employed in the metastatic setting, not in the curative setting. But most of them can be used, depending on your geographical location and FDA approval, some can be used for the management of bone mets for breast and also for bone. But it's very expensive, okay? It's very expensive to import the radionuclide. Now let's look at external beam radiation. With external beam radiation, we are coming from outside in. Everybody here has taken an X-ray before. You go, you're at the far end of the room, the machine is at the other side, breathe in, breathe out, if it's a chest X-ray. Okay, we are done. Within that second, 3 or 4 seconds, yes, you've been exposed to radiations, and the source is closed. And then an image is produced. That radiation is just to produce an image. It doesn't cause that much damage to the body, okay? But we are using very high doses, and therefore we are very precise with the treatment, and when we are not sure, we won't even treat because we can cause some damage. So this is just an image where you can see this is the source of the radiation. We call it the gantry head, okay? You are exposed. The radiation comes from here all the way to the target, and as you can see, we are treating a very specific area in the brain. And that's the area that receives the radiation. The surrounding area receives minimal radiation as much as possible. These are images from our treatment planning system. The patient on the right, again, was a breast cancer patient who came in with bone pain, difficulty walking. A CT scan picked up mixed lesion in the distal femur, and it was threatening to fracture because of the pain, and there were also lytic lesions in the knee joint. So we radiated just that side. So the area, the green line you're seeing, is where we call the 95 isodose line, where 95% of our prescribed dose is deposited. Outside this region, there's a sharp dose fall off from 95. So outside here, you can have as low as 2% of radiation going there. And therefore, we're able to spare all of this. But this is even a two-dimensional treatment. A three-dimensional treatment where we just put fields on. We were not really narrowing down just on the bone. So even with this, there was so much exposure to the surrounding soft tissue. The image on the right is also, this one was for prostate cancer. Patient came in with back pain. Imaging showed, you can see this lesion here. This is at 5, 4, 3, 2, 1. Okay. L1 vertebra in the body. And therefore, we radiated the bone above and the bone below. And the red line you're seeing here, we actually call it a contour. So we sit down. You can just imagine this. We sit down with a pen or a pencil, and then we draw the area we want to radiate. And afterwards, we can actually plan how to deliver that radiation just to that area. And therefore, we minimize the amount of radiation exposure to surrounding tissues. So you can see that the abdomen is not receiving any radiation. The vertebra above and below is receiving minimal radiation as much as possible. Historically, we started from a two-dimensional image whereby we just use X-rays, okay? X-ray. So we call it a conventional simulator. In the image above, that one, we're treating the whole brain. Patient had metastatic disease to the brain, had multiple sites, and therefore you couldn't just do surgery for that site, and we're treating the whole brain. So these lines you are seeing here is a block. So we are blocking this area from receiving radiation. So the eye, the globe is not receiving radiation. The mouth region, the oral cavity is not receiving radiation. But with this one, we are treating all of this area. So left and right, that's a two-dimension, and then we treat. So the exposure here is high, and that is what is showing here. So all the green area is receiving radiation. Usually we do this for patients who have multiple disease in the brain, and we need to control all the sites at the same time. Over time, we have started narrowing down on just the area that we want to treat. That's what we call the three-dimensional treatments, where we just draw that area and we target it with radiation. And we have different techniques we do. We have the intensity modulated radiation therapy, the volumetric arc therapy. And currently, we are now here. We're just targeting the lesion and avoiding radiating all these parts where the green is and the blue are. Those are areas exposed to radiation, but now we are just limiting it to this area. We call it stereotactic radiosurgery and stereotactic SBRT and SRS, yeah. But we're able to give a very high dose just to this area, a very high dose at a go, and avoid radiation, excessive radiation to the surrounding brain. So you can see that most of the brain is spared. That is where currently radiation oncology is heading towards. And actually, that is where we have reached now, actually, and this can be done in Ghana. Okay, so I've spoken about this. So even with multiple brain lesions, now we can just target those areas and radiate. But the risk of doing this, especially when you have multiple lesions in the brain, is that, okay, what about if there's a microscopic lesion here, which has not showed itself up yet? Especially the patient already has multiple lesions in the brain. So the argument is, do you want to radiate the entire, do you want to just limit it to those lesions, and later on another one will come up for you to radiate that area? Yes, there's room for that, okay? But then you also have to look at side effects, because one of the long-term side effects of whole brain radiation is amnesia, long-term amnesia, and that can affect quality of life. And therefore, as Edwina said, precision medicine. Precision medicine entails patient-centered care. What are the parameters of the patient? What is the wish of the patient? That is where we are now. This is for breast cancer, which is the #1 cancer in the country at the moment. So, as I said, we take our time to draw out structures, okay? So we have drawn out the breast, and our surgeons will appreciate we've also drawn level 1 lymph nodes, level 2, level 3. Okay, so it's not just exposing the patient to just anything, but we are very precise with our treatment. We also contour the heart, the lungs, because we need to know how much radiation these organs are receiving. And there's a limit. There's an acceptable dose that must go there with acceptable side effects. Okay? If we're exceeding it, we will not treat. We'll find another way around it. And even we contour the tumor cavity. So this patient underwent breast conservation surgery, had neoadjuvant chemotherapy, followed by surgery, and now was undergoing radiation therapy. We contour the tumor cavity as well. And that is how come now currently our surgeons are leaving in clips at the tumor site for us. It will help us delineate that tumor cavity and give an extra dose there. And the whole idea about giving the radiation is to prevent in-breast tumor recurrence. So afterwards, when you do a 3D reconstruction, you can actually see the breast that is going to be treated, the tumor cavity where the tumor was taken out of, the lymph nodes, And when we plan the radiation, this is how it looks like. So this image is showing where we are radiating. This is the whole breast. And as you can see, there's minimum exposure to the lungs. The green area is receiving 95% of the dose, and outside this region, there's a sharp dose fall-off. The lines you are seeing here talks about the direction of the radiation, how we position them. And there are more, but we just limited it to these two. Depending on the patient and the parameters we meet, we'll decide the technique we'll use and how we'll go about it. And also, this is for the tumor cavity alone. So afterwards, after radiating this entire breast, we then boost, we give an extra dose just to the tumor cavity. And there's an overall survival benefit for radiation. Currently, for breast cancer, breast conservation surgery followed by radiation has an overall survival benefit and improved quality of life compared to mastectomy. I know this is an argument we've been having with the surgeons for a long time. But the current evidence, and this is a meta-analysis, the current evidence suggests that actually it's better compared to mastectomy. This is for head and neck. So for head and neck, I know most of my colleagues don't like head and neck, but it's lovely. Pardon me for this. But, it's one of the areas I am interested in. The head and neck space is relatively fixed, and this is a three-dimensional view of contoured tumor and areas of treatment. So the blue here is the parotid gland. There's also the parotid gland. The green you're seeing here, this green is the brainstem. Then I have the eyes, I have the optic nerve, I have the optic chiasm, all of which I have contoured. And then I contour where the tumor is. So if you can see this, there's a yellow within the blue here. That is where the tumor is. This was an oropharyngeal tumor, specifically it was the tonsil, with neck nodes. So you can see another, whether red or pink, in there within the blue. Those are areas of the gross tumor. And then afterwards, we put a margin on it to account for microscopic disease and set up errors. So the area that we're treating is this entire area. And this line you see here is the spinal cord. So therefore, we account for every structure, and we make sure that we know how much radiation each structure is getting, just to make sure that we don't exceed the tolerances. At the end of the day, this is how the plan was. As you can see, it's just limited to where the tumor is. And the brainstem is spared, the brain is spared. You can see here, it's just limited to where the tumor is. And for the neck nodes, similar. So this is the chemo suits. I just wanted to show some images. This is how a chemo suit setup is. It's similar to what is in Cape Coast Teaching Hospital, and we are hoping it will get better. These are radiation equipment. So this is the linear accelerator, popularly called the LINAC. This is in the country. This is at the Kolebu Teaching Hospital. Konfuanochi has a similar setup, and also SGMC, Sweden Ghana Medical, has a similar setup. You'll notice that most of my images, when it comes to radiation, because we are very precise, we need a higher imaging, not a two-dimensional imaging, and therefore we do a lot of CTs. So we have an in-house CT scan at the Kolebu Teaching Hospital, and most radiation centers also have an in-house CT scan. Our precision, because of our precision, our requirements are a bit different compared to our radiologists. Their slide cuts are very wide. They can do 5 millimeters and above, but I want a very fine cut because I don't want to miss any tumor. So we have a cut of sometimes 2.5 millimeters or less. So you come and find Dr. Edwina sitting behind the machine, and she's going through almost 500 slides just to contour a tumor so that we don't miss anything. And therefore, we call it a planning CT scan. This is different from the diagnostic CT scan that the radiologist does. So you hear us talking about planning CT scan, but it can also double as a diagnostic CT scan because they can review the images as a CT scan and then tell you what, give us a report on it. The setup is different because I have to replicate the patient position throughout treatments. So you can see this thing over here, and you can see these masks, these white things here. So when we are doing head and neck cancers, when we are treating head and neck cancers, we actually mold this. over the patient's face so that we can fix the head. Because when I'm radiating, I'm just putting in algorithm and putting in data into a computer to tell the computer, okay, when you get to an angle of 2 degrees, give this amount of radiation. And therefore, if the patient moves, I'll miss my target. And that's one major difference between a diagnostic CT and a planning CT scan. So we fix the head to the board, and the angulation and everything is recorded and replicated throughout every day of the treatment. Depending on the patient's site, there are specific things that we do to set up the patient. What is the role of radiotherapy in cancer care? It improves overall survival as a single modality treatment or in combination with other treatments, especially in head and neck cancers. We give it concurrently, that is together with chemotherapy. It also helps to decrease locoregional recurrence and disease-free survival. Improves the quality of life of patients, especially patients that we cannot cure. They have metastatic disease. We can radiate just the site that is giving them a problem. Like the bone mets picture I showed you, we can just radiate that site to help alleviate their symptoms while we focus on systemic therapy. So we use it in the curative setting. We use it in the palliative setting as well. And we also use it in the curative setting for some benign lesions. Some benign lesions, not all benign lesions. Some are not radiosensitive. But even for cancer cases, it's not every cancer that is radiosensitive. It's not every cancer that's radiosensitive. Some are not. And therefore, for those ones, the mainstay treatment is still surgery. For instance, adenoid carcinoma, mainstay treatment is surgical. And therefore, I left a comment here, an incomplete oncological surgery is really not an indication for radiation except in specific cases. And therefore, for our surgeons, when they are going in their oncological principles, currently, it's in very few cases. I will just say that maybe only in thyroid CA. Even that one, at MDT, we may decide to go and do a debulking. Aside that, debulking is not really encouraged. So you don't go and debulk and say that, okay, let radiation take care of the rest. It doesn't work that way, okay? Now let's look at systemic therapy. What is systemic therapy? This entails the use of medications that travel through the body, okay, to find and destroy cancer cells. They can be cytotoxic, resulting in the death of cancer cells, or cytostatic, actually not cytotoxic, but cytocidal, okay, that kill the cancer cell, or cytostatic, they just arrest the cancer cells, okay, and it depends on which medication you are using and its mechanism of action. The systemic therapy is often personalized based on the tumor biology, and that is why we need the pathologist. That's why one of our closest friends is the pathologist first, before our surgeons come in. And also, it can be given in combination with radiotherapy, as I said earlier on, in the concurrent setting, and both can promote improved survival, disease-free survival, and quality of life. What are the types and the examples? So we have immunotherapy, we have chemotherapy, endocrinal therapy, and targeted therapy. Under chemo, this is just some examples. The common ones we use for breast: adriamycin, cyclophosphamide, paclitaxel, docetaxel, methotrexate, platinum-based chemo, carboplatin, cisplatin, vincristine, vinorelbine. Immunotherapy, these target specific receptors. On Dr. Olsen's slides, you saw PD-L1. So we can target it with pembro. We can target, we can do atezolizumab. For targeted therapy, we have trastuzumab, which popularly in the country, you know it as Herceptin by the brand name. We also have erlotinib, osimertinib for EGFR. Under endocrine, we have the SERD, the SEM, so we have our Arimidex, we have our tamoxifen, there's fulvestrant in the country. We have our Zoladex that we use. We also have palbociclib. So most of these medications I placed here are available in the country, but some of them you need to have cash. Yeah, you need to have cash, and I'm not talking about having 1,000 Ghana cedis, but yes, some of them you need as high as about 40,000. Okay, so yes, 40,000 a month. 40,000 minimum for a month. For instance, for pembrolizumab, you need about 40,000 a month for 200 milligram minimum. And therefore, and it's given in the metastatic setting. So you can imagine if the patient is responding, then we have to continue until progression. Now, we can just conduct a survey right now. How many of us can afford 40,000 a month? I can't. I don't know about you. What are the indications for systemic therapy? So mainly curative treatment of cancer alone or in combination with systemic therapy and also sequentially with surgery. In the palliative treatment of metastatic disease, and also sometimes, in some very rare instances, some chemo medications have been tried for benign disease. However, the results are not promising, but it has been tried. For instance, for fibromatosis, I think they tried, what's the name of that drug? They tried one of the chemo medications, it has escaped me, but the results were not that promising. Even hormonal therapy, tamoxifen, has been attempted in fibromatosis before, but it's not that promising, but, well, there was some disease-free survival for a while. So in some occasions, we can use this for benign disease. It can either be delivered oral, and most of the oral, some chemotherapies can be given oral, like capecitabine, which is the oral formulation for 5-FU, 5-fluorouracil. Most of our hormonal medications are given oral. Arimidex, exemestane, tamoxifen, letrozole, these are all oral. And targeted therapy, osimertinib, is currently available in the country. It was launched by, what's their name? AstraZeneca, yes, last week. We went to eat some good food, but I don't know about affordability. Erlotinib is also available in the country. In terms of intravenous medications, most chemotherapy medications are IV. Targeted medications like trastuzumab, which is available in the country, is IV. It's IM, sorry, it's IM. We also have, what's the name of the combination, trastuzumab, the HER2, HER3. It's also available. Yes, trastuzumab, pertuzumab is also available in the country. Endocrinal therapy, fulvestrant, is available in the country. This all requires money. So we have the oral formulation, IV formulation, IM formulation, and the choice depends on patient parameters, the tumor biology, the stage of the cancer, and the current evidence available, as well as patient's wish. So I've already spoken about this: improves overall survival, improved quality of life, decreased locoregional recurrence, can be used in the curative and the palliative setting. In terms of sequencing, whether radiation or chemotherapy, basically you heard them talking about neoadjuvant, adjuvant. In the neoadjuvant setting, we give the medication or the treatment, we give some form of treatment before surgery or before some definitive treatment, including radiation, so surgery or radiation, depending on the cancer we are talking about. And usually in the neoadjuvant setting, it's systemic therapy that we give. So chemotherapy or hormonal medications are used. In some breast cancer patients, we can do neoadjuvant hormonal therapy. These are very strong luminal A patients because they would not respond to your conventional chemotherapy, and quite early stage 2 as well. But we've seen some locally advanced cancers who are luminal A who didn't respond to anything. I think we discussed one at MDT last 2 weeks where a patient had a T4C N1 M0 disease, luminal A. She had our conventional neoadjuvant AC, didn't respond, and therefore was switched to Taxol based on an NSABP 18 and 27 trials. And still, she didn't respond. So we decided to switch to hormonal therapy because she's strongly luminal A and postmenopausal. And we just placed her on Arimidex. It's about 10 weeks now when we're discussing at tumor board. The lesion has shrunk. It's now a T1C. It's about just 1.1 cm. And now they are considering going in T1C N0. So it's a YC T1C, from a T4C N0, N1 M0 to a YC T1C N0 M0. Patients, and this decision was at tumor board. It was not just a monodisciplinary decision, okay? So patient selection must be done at tumor board for some of these cases. Concurrent treatment involves the combination of two treatment modalities that go together. So for instance, for most of our head and neck cancers, the evidence suggests that concurrent chemoradiation is the gold standard of treatment. For instance, in nasopharyngeal cancers, in oropharyngeal cancers. And with this, we combine the two. So in oropharyngeal cancers, for instance, we do 3-weekly cisplatin with radiation therapy. So the patient is receiving radiation, and on specific days, the patient receives chemotherapy and radiation on the same day. And that alone is definitive treatment for them. So they would not require surgery afterwards. In this setting, surgery becomes salvage, not curative. Now we have the adjuvant treatment, whereby after your definitive treatment, you then give further systemic therapy based on the evidence available. So for instance, in hormone receptor positive patients, based on the early breast cancer trialist groups and other research, you realize that we put patients on a minimum of 5 years of hormonal therapy based on evidence available. Also, radiation can be given in the adjuvant setting, in the setting of breast cancer, after surgery. So in that setting, it's adjuvant after the main treatment. So systemic therapy and radiation, as well as surgery, can be given in this order. I came across this note when I was reading Palumbo et al., and he stated that actually we've heard this before, even in this country. Unfortunately, I can't speak this language, so I wouldn't even bother trying to say it. But the English translation was that you are nothing but someone who poisons people. That was so many decades ago. That was how medical oncologists were seen. Okay? You're nothing but you just poison people because people think that we give poison, cytotoxic treatments, chemotherapy to the patient. However, every medication that you give to the patient has side effects. It's just the percentage of side effects and whether the risk outweighs the benefits that counts. Over the years, we've had so much research ongoing. And I remember at one conference that we attended, one professor said that when he started practicing medical oncology in Egypt, the only medication that was available was tamoxifen for hormonal therapy for breast. That's the only medication that he knew how to prescribe. But in his years of practice now, he has lost count of the combinations we can do, all with the aim of cure. So this has evolved over years. Cancer is evolving. All the disciplines of cancer is evolving. In conclusion, radiotherapy provides precise, localized treatment. So just like surgery, radiation is localized. It doesn't go, except when you're doing internal radiation using radionuclide. It plays a critical role in the curative treatment for inoperable disease. In some cases, it's actually the mainstay treatment. It reduces local recurrence and improves survival. And also, it can do this when combined with surgery and other systemic therapies. Systemic therapy does a similar thing, improves local recurrence, improves overall survival, but all of these comes with some side effects, which we take time to discuss with the patients. These are my references, and before I conclude, I would like to say that even here, we've heard the use of radio-oncologists. We are not radio-oncologists. It doesn't, that terminology does not exist because it's confusing. Is it a radiologist who is doing oncology images or what? So it's radiation oncologist or medical oncologist or clinical oncologist. A clinical oncologist does both radiation oncology and medical oncology, which in Ghana, because of limited clinicians, we have to do both. But I know some of my colleagues who run away from medical oncology if we are given the chance to. But I think currently we are less than 30, or we've crossed that bar in Ghana. Yeah. I think we are less than 30 clinical oncologists in the country. Okay. So this is my conclusion, and I'll quickly jump to the last presentation for the day. This is a research that we conducted at the Cape Coast Teaching Hospital when we started oncological services. And we looked at recommendations of MDT and compliance to radiation therapy treatment in a region of Ghana, initially without oncological services. And as Auntie Magdalene said earlier on, we started barely about 5 years ago. And even 5 years ago and now, the story of oncology in Ghana hasn't changed. It has changed a bit. Okay, yes, it has changed a bit, but it's still evolving, but at a very slow pace. We have 3 fully equipped oncology centers in the country which practice clinical oncology. That is both radiation and medical oncology. One is the oncology department at the Komfo-Anokye Teaching Hospital. The second is the National Radiotherapy Oncology and Nuclear Medicine Center at the Kolebu Teaching Hospital. And the third one is private. That is the Sweden Ghana Medical Cancer Center. They are now having a PET scan, which the other 2 facilities doesn't have. So that hasn't changed much in the country. There are still paperworks and proposals to establish more centers in the country. But if you wanted oncological care, these are the centers that you were referred to, and the patient burden was very high. In 2019, after further discussions with the Cape Coast Teaching Hospital, we decided to do an outreach service. Back then, we were still in training. So an outreach service to the Cape Coast Teaching Hospital so that medical oncology services can be started. Over the years, aside the Cape Coast Teaching Hospital, other institutions have also started doing medical oncology services, just to buy time, because you can give these systemic therapies without necessarily having to be in a radiation facility. And so in the year 2020, it was started. And it started with MDT discussions, so we had collaboration between the surgeons in Cape Coast. Then, as I said, we were still in training. We had oncologists coming in from Accra, and we're part of the team. The objective of this paper was therefore that over that period, we wanted to analyze the clinical pathological features of the cases we discussed to determine the patterns of recommendations made at the meeting and examine the demographic factors that influence compliance to radiation therapy recommendation at these meetings. So we looked at data. So actually, the chemotherapy unit was commissioned in 2020. But then before then, we had already started operations. So operations actually started in 2019. So MDT started around August 2019. So we looked at data from 2019, August 2019 to December 2021, looking at cases that were discussed at MDT. Cases that were seen at the clinic were excluded, okay? And it was a purposive sampling technique. Also, hem-oncology cases were excluded, pediatric cases were excluded. These are not discussed at this tumor board. They are discussed at a different tumor board altogether. Yeah. We also excluded cases that were coming outside Central and Western region. We noticed that a total of 214 patients were discussed during that period. And after cleaning the data, 179 were included in our data analysis, because some of them, data was incomplete. Actually, when we started, some cases were discussed without histopath, and these patients were lost after a while. Some patients, their biodata was incomplete. We don't have the age, we don't have where they live, and therefore they had to be excluded from the trial, from this study. The male to female ratio was, it was interesting. As usual, our females were actually higher than the males. So 63.9% of the cases we discussed at MDT were actually females, as compared to 36.1, with a ratio of 1:1.7 for male to female. With a mean age of 54.7 years, sorry about that, about shown in table 7. This is the age distribution, so you'll notice that most of our patients were between the ages of 55 to 64 years, and we were still seeing patients who were 75-year plus. Now, the Ghanaian population, we are living longer because of some of the interventions that we have in the country, but there's still room for more. And then for patients less than 25 years, we saw a couple of them, 3.4% of the population were that. In terms of site of malignancy, as usual, just like the GlobalCon data and even Ghana statistics, breast was the highest. 45% of cases discussed were breast, followed by prostate, which Dr. Fori brought a lot of cases for us to discuss. Then head and neck. This comprised of nasopharynx, oropharynx, laryngeal cancers, followed by colorectal cancers. Now you notice that in the GlobalCon data, in the top 5, there's liver cancers, but it's not reflecting here. Interestingly enough, we didn't discuss any case of liver CA. but liver CA is in the country. Yeah. Oftentimes, our internal medicine physicians see sometimes, for some reason, by the time they see it's late. So mortality with liver CAs in the country is high. We're trying to change the narrative. Okay. You realize that gynae cases were just 2.8%. It doesn't mean that we do not have cervical cancers in the country. It's part of the top 5. We have ovarian, we have cervical cancers. But the thing was that most cases that were seen were referred directly to either Kolebu or Konfanochi, depending on patient's preference. And at the initiation of tumor board, they were still being referred directly without coming to tumor board. So the picture here doesn't really reflect the number of cases, the gynae cases we see in the country. And as usual, we have our urinary bladder, some intra-abdominal lesions, and all that. In terms of stage, most of the cases we saw were stage 3, locally advanced. Now, this is a mixture of all the cases, so breast, prostate, whatever, but locally advanced. And that is the narrative in the country still. Well, gradually, we've stepped down from metastatic, but metastatic is still quite significant. Stage 4 diseases are still quite significant, but we're coming down to locally advanced. Hopefully, we're hoping the narrative changes to stage 2 and stage 1. Okay? Most of the cases, and we still had cases that were not staged because, well, they had a histopath and all that. The team was supposed to go back, do some imaging based on the recommendations of the MDT and come back, but they were lost to care and follow up. Treatment intent. Majority of our cases, 63.1% of our cases could undergo curative treatment based on MDT discussions and decisions, and 30.7% of them palliative. So which means that more than half of our cases, even in the Western and Central region, can still be cured. Remember, they are stage 3, not stage 4, and therefore we can still cure them. And just about 6.1% of them we couldn't determine. As I said, they were incomplete data, so we couldn't determine, or it wasn't straightforward. We needed further investigations to be sure. In terms of modalities of treatment, we have surgery, systemic therapy, radiation therapy, and supportive care. Just about 1% of our patients require pure supportive care without any intervention because they were not strong enough. And some of that group of patients is not necessarily because they were stage 4, but maybe because of comorbidities, because of age, and other patient factors. Majority of our patients required radiation therapy as part of their treatment, as high as 68% of them, followed by systemic therapy, which was 85%, and surgery. Just about half of our patients required surgery. Okay, so just as Dr. Prof. Mason was saying, they are now moving more towards organ preservation, and even in oropharyngeal cancers, surgery is not, unless you're going to do a palliative surgery for another side, but for primary oropharyngeal CAs, the mainstay treatment is still concurrent chemoradiation. Yeah. And 38.5% of our patients required all the 3 treatment modalities. Yeah, 38.5% required all the treatment modalities. 18.4% required systemic therapy alone. Just 1.7% required surgery alone without the other modalities for their treatment. And 6.1% of the patients required radiation therapy alone for treatment. So you realize that patients require more systemic therapies, and therefore we can do this outside oncology, fully set up oncology centers. And this is one of the drives. So there are centers, not necessarily centers, but facilities now offering medical oncology services, especially some of the regional facilities, and they have trained clinical oncology nurses who are present to administer these medications after discussion at MDTs, okay? So even though they don't have a tumor board in-house, the country has zones where they can discuss some of these cases. So the Northern region, for instance, has a tumor board meeting with the team from Konfanochi. So they join on, and then cases are discussed. Those that require purely systemic therapy is done in the North, those that require systemic and radiation, depending on which one the sequencing, they'll know how to go about it. In terms of distribution of our patients' location, the green was for patients who are in the central region. The red was for patients who were then in the western region. Now it has been divided into two. Yeah. So, pardon me for use my choice of words, but this was for western region. This was for central region. You realize that far getting to this corner, we were seeing cases from here. Okay. The number of dots is not equivalent to the total number of cases. It's just the location of patients that were seen, okay? And there were some outliers. Remember, the inclusion criteria was for patients who were in the central and western region. We had cases coming all the way from Sunyani, and they crossed the Ashanti region just to come to Cape Coast for care. Yeah. There were multiple factors, not just relatives and all that, but yeah. So this is just a line showing you where they travel to Cape Coast for care. And for patients who have to travel all the way to Accra for radiation, or previously, this was how the trajectory was. Patients had to travel all the way from here to Accra for care and for initiation of care. And we cannot see all the cases in Accra at a go, so they will have to be booked. Okay, and the current booking is even is long. In terms of distance travel, the average distance that was covered by patients to CCTH for care was about 49.5 kilometers with a standard deviation of 47 plus or minus 47.7 kilometers. The least distance was 0.6 kilometers. That was from Abra to the hospital. And the longest was 221 kilometers. That's far. For radiation services in Accra, you had an average of 161.4 kilometers. And the longest distance was 361 kilometers. You're just sitting in a car just to travel to Accra, just to have chemotherapy every 3 weeks, or radiation therapy. Or just to be told that, oh, maybe the surgery took out everything, and that's all. So you don't need any further treatment. Or just to go for 3 monthly follow-up, you have to sit in a car for 361 kilometers. And therefore, there's a drive to change this narrative. And that's how come we are looking at the data, because the data must speak for itself to make noise. That, yes, you need a fully set up oncology services in this part of the country. Then we looked at factors that influenced care. Why patients were going to, why the patients actually followed up with a recommendation for radiation all the way to Kolebu. And we realized that most of the factors, the factor that was influencing care was mainly occupation, okay? Occupation, with a significant p-value, mainly occupation. The educational level really doesn't impact whether the patient will come or not. So we had very educated people still not coming or following up on treatments, yeah. And you also have the least educated not coming. It's quite interesting, the data is quite interesting. Yeah, okay. Gender really, there wasn't that much difference in terms of treatment, whether it was curative. Maybe we were thinking that when we tell you that we can cure, maybe that will push them to come. But no. The intent of treatment did not really play a role. The age did not really play a role. And therefore, in terms of factors influencing compliance to treatment, we noticed that male patients and those who were skilled professionals showed a higher adherence, reflecting trends in other country settings, where men often have the greater financial independence compared to women and fewer caregiving roles, facilitating treatment access. So we alluded to the facts from other studies in other African countries that stated that most of our male, in Africa, the male is the one that controls the finances in the home. Okay, but I say this with a caution that the trend is changing. Yeah, I know some women that are richer than the men. And, yeah. And please give us some of the money, anyway. So, most of the males carry the money, and therefore, health-seeking behavior, they can easily access the care. So we're thinking that, okay, seeing this trend, it might be similar to what we are seeing in other African countries. But this is different from the Western world, where there's a sharp difference. Conversely, in high-income countries, women often demonstrate higher adherence, supported by awareness campaigns and structured breast and cervical cancer campaigns. So in Western countries, the women are driving. They are the ones actually seeking care more. They are the ones going for the mammogram. They are the ones going for the pap smears because they have the financial stability to do so. Okay, that is not the picture that is seen in Africa. Unexpectedly, distance from radiation center in Accra did not affect compliance. Okay, they went, whether it was far, but those who had skilled labor went, males went compared to females. Okay. Psychosocial factors such as trust in healthcare, stigma, and fear of radiotherapy side effects remain critical, but they are really hard to measure. Okay, we still have a lot of stigma associated with radiation. Even among healthcare workers, there's a lot of stigma. Even Dr. Inti will beat me, but even among radiologists and radiographers, yeah, there's still a lot of radiation and yeah, okay. So education really, whether you are well educated or not, the question is what exactly goes into those education in terms of radiation? What do they know? Because people are carrying a mentality out there. Okay. For limitations of this study, it was retrospective. It was just limited to a short period of time when MDT was started. The exact cost implication of traveling, pardon me for the typo, for care was not assessed. Okay, so the cost implication, because around that time we had COVID also coming in, where there was also fluctuation in prices. The economy was not stable, so prices kept changing. And therefore, we decided not to add that to the cost implication of traveling for care to the study, because we really couldn't measure. Prices were changing by the week in terms of cost of care and where the patient goes to lodge and all that, so we couldn't assess that. Also, only cases that were discussed at the MDT were included in the study, and not all cases seen or cases that passed through the oncology clinic were added. So this was just limited to just the cases that were seen at the MDT, and therefore it does not reflect the entire patient spectrum seen at CCTH. Okay. In conclusion, the study underscores the multifaceted role of MDTs in Ghana, MDTs in cancer care at CCTH, revealing both progress and challenges, while MDTs facilitate expert-coordinated recommendations, systemic barriers on one hand, late-stage diagnosis, limited infrastructure, gender disparities, and socio-economic constraints on the other hand, impacts treatment implementation and patient compliance. This data is yet to be published. We're in the final stages of publishing it, so it will come out soon. Ethical clearance was it was ethically approved before the study was started. The current updates of cases that are seen at CCTH, Auntie Magdalene started talking about this. So from 2020 to 2024, our 2025 data is still evolving. We've seen 1,130 cases at the oncology clinic so far. Okay, some of these cases were seen at MDT and then came to the clinic. Some of them were just seen at MDT and they were referred straight to Kolebu or other radiation centers for radiation therapy. And so those ones did not come to the clinic, so that's not part of the oncology clinic data, okay? Then we have those that were discussed at tumor board meetings over the period. We have 1,105 cases that have been discussed so far at MDT. This is minus cases that came directly to the clinic without passing through MDT, because they were referred from a peripheral facility straight to oncology. Okay. In terms of trend over the years, this has been the trend. So the blue was for tumor board meeting discussions, and as you can see, there was a small dip during the COVID era, but it is also rising again. The cases that are seen at the clinic is gradually rising, because we are not just seeing cases discussed in-house from CCTH, but we are seeing cases from the periphery. And it will interest you to know that I think we saw a case, we've been seeing cases all the way from Liberia at CCTH, okay? Okay, thank you, and we'll take questions.
That's a lot of information. That's a lot of information. Nice presentation. Please, let's clap for him again. So, when are we seeing the paper published?
By the end of the year to come out.
Wonderful. My data is inside that. So, anyway, So we are almost coming to the end of the program. We have the MDT session. We'll have about 15 minutes. So I think two people have sent us MDT. So let's do that quickly. Urology, are you ready? Please, if you have questions, note them down. We'll be taking them shortly. Lunch, we're going for lunch in the next 15 minutes, so we'll try and do it fast. Hello, please, can you put by hand those who have experienced MDT session before? Yes, or have sat in an MDT session. A few people, okay. At least almost half of the audience, okay.
So I'm Arthur Augustine. I'm presenting on behalf of urology. So we have two cases. So I'll go straight to the first case. Okay, so Mr. AO, 64 years, he presented with lower urinary tract symptoms. Initially, when he came with a PSA of around 20, but a repeat PSA at a different lab was 50. DRE finding was benign. Ultrasound also was suggested an enlarged homogeneous prostate. However, the PSA was 50 and a biopsy was done, which shows adenocarcinoma, Gleason score 3+4. Did a whole body diffusion MRI, which came out to be normal, but we requested for pelvic MRI, which he is yet to do it. It's ECOG 0.
Okay, so my first question for urology is, what's your risk stratification?
It's a high risk.
On account of?
The PSA being 50.
Okay. Any suggested treatment from urology?
Yes, so we think based on the PSA, the whole body diffusion MRI was negative for MET. But if we are going to do the pelvic MRI, but based on the PSA, if there's no, we think he might benefit from external beam radiation plus Zoladex injection.
So the patient has been informed of having a pelvic MRI done, right?
Yes.
A multiparametric pelvic
Yes.
MRI, because we also need to know whether there's seminal vesicle infiltration. That would change the risk stratification and the treatment plan altogether. Okay. For high risk, there's room for brachytherapy with external beam radiation boost, and also 2 years of androgen deprivation therapy, all with the intent of cure. Okay. So will your patients want this to be done?
Yes, the patient is very ready.
Yeah.
So the next case.
But please encourage him to do the pelvic MRI. Yeah.
All right, sure.
Okay.
So this
the plan will change once the pelvic MRI picks up something different. The plan will change.
Yes. All right. So this is the second case. Also, BOs, he presented with retention of urine. He also came with a very high PSA. The PSA was 343. Biopsy showed adenocarcinoma, Gleason 3+3. He did a whole body diffusion MRI, which was normal. The pelvic MRI showed some enlarged left para-iliac lymph node. He's ECOG 0.
He has a left iliac lymph node.
Yes.
Okay. Is it, okay, we'll look at the images, but we would want to see exactly where that is, whether it's in the external or internal, and is close to the prostate. If it is, we can include the entire field in our radiation plan. So he's a high risk on account of the PSA being high. What's your T stage? Rectal exam?
Yes, it was palpable digitally.
Okay. All right. So he would also benefit from it's interesting. He would benefit from 2 years of androgen deprivation therapy with abiraterone and external beam radiation therapy. Okay.
May I know why the abiraterone?
He has a lymph node.
Okay.
That's what it goes. Yeah, he has an advanced disease.
Okay.
Okay. And there's evidence to show that abiraterone for very high risk patients decreases, improves overall survival and disease-free survival. In our setting, the main thing is the cost implication, but now we have generic brands, and therefore the cost is coming down. Now, I have a comment. The bicalutamide, any reason why you do 150?
So we've been having this. We're also aware sometimes we want 50 milligrams, especially before we want to.
So, are you giving it as a monotherapy, or you are giving it in preparation for a full blockade with ABT?
For him, for now, to be honest, we are not giving it in preparation for that. We are giving it for a treatment, for monotherapy.
So we just switch to ABT.
Okay.
And I actually wanted to suggest something for urology. So today you realize that from staging and then the risk stratification, we did mention that there are some parameters you need to pay attention to. So your T staging is very important. Always note your T staging for us. Urologists are very good with the DRE. You are able to actually get to the seminal vesicles better than we. So we'll need you to state all that and what your T staging is from your DRE. And then from the pathology reports, we are not just interested in the Gleason score. We are also interested in the, so you add a grade group, the tumor percentage, percentage involvement of the cause. It's also very important to add all those things because we put all those parameters together to determine the kind of risks the patient has. Isn't something a bit weird about your patient? Why is Gleason score 3+3, but he has a PSA of 200 plus?
Yes, I have the pathology reports of all of them here.
No, I'm just making...
It's very weird, yeah.
I'm making you aware that there are some things you need to look out for. So when you are reporting, please include all those things in it.
Okay, all right.
Thank you.
All right, thank you very much.
No, Dr. Quick, I wanted to find out about the bicalutamide, the 150 milligram. So now, is it now a norm that you do the 150 milligram, and how long do you do it, the bicalutamide?
So when we are doing it in preparation for the Zoladex, we give it for 50, that will do 50 for 3 weeks. And then 1 month, okay. And then you do that. But for this one, if we are, what we are doing now, as soon as we start the Zoladex injection, we stop.
Because it looks like it's becoming a trend. I've seen a patient that has actually been on bicalutamide for 6 months, 150 milligram.
For 6 months.
I don't know, maybe there is something along the path because for them, they can easily go and buy and then, so I don't know whether it's the counseling or because there was this old man that I saw, for him, he said they told him to go and prepare and then come and get the Goseril and the Zoladex. So every month, it's been over 6 months, every month he goes to buy but I don't know why he buys the bicalutamide. And he's not ready with the money yet. Okay,
so let me explain why it happens like that. I've seen, and there are quite a number of patients like that. It's because some of them, when we cancel them, let's say for ADT, chemical or surgical, they don't want the surgical. They want the chemical.
Will you take surgical?
But the chemicals they can't afford, and they will tell you that they are gathering money, and it will take a very long time before they come. So that's how it happens like that. Yeah. If I cannot afford, I want surgical.
You want surgical?
If I cannot
Anyway.
afford,
The other thing is, in the absence of Zoladex, well, it's an option. It's an option. Erectile dysfunction is much better with bicalutamide, but the mainstay treatment is to do GnRH agonist. Okay, and therefore the counseling is key. What we tell the patient is key. The other thing is you made a statement that, okay, you start the GnRH and then you stop. Do you stop immediately?
no, usually continue for a week and then you stop.
Okay, can you educate us why? For the purpose of everyone here.
Thank you very much.
Thank you very much.
It's an MDT.
Timby, who is presenting for Timby?
All right, I'm Ebenezer, presenting for Team B. We have 3 cases, all breast cases. So, Madam G.O., a female, 40 years, 40-year-old, ECOG 0, clinical stage CT4B N2A M0. She's triple negative. Histology, invasive carcinoma NST. She's premenopausal. Because of time, I'll move faster. So she had a lesion for about 7 months. She had peau d'orange. She presented to us with that mass and then peau d'orange. We did the core biopsy. So there's a mistake on my slide. It's triple negative. All right. But for the metastatic workup, there's no distant met. So we are planning on to discuss it, our plan at the back of mind to do neoadjuvant, then do a modified radical mastectomy, and then adjuvant chemotherapy.
So,
Adjuvant radiotherapy. So it's triple negative, sorry.
all right.
Triple negative.
It was a
It was a typo, yes.
You mentioned the molecular subtype, but from your mammogram,
Yeah.
what was the tumor size?
I think, let me go back.
No, you only stated is virus for. Okay.
This clinical,
Yeah.
I've forgotten the values of head here.
Okay. So today I'm just going to draw your attention to the fact that there are some things you need to state. You need to state the tumor size that the mammogram measured, and then where it was located. It's very important to let us know all that. And when you are referring the patient, to even include all those things to us as well. But that said, it's a T4B.
T4B,
Yeah.
N2A.
N2A. So do you have, like, if you look at it, is it something that is upfront? You can go ahead and do upfront surgery or something? No. It's a question I'm
It's
not
10
saying.
cm.
Pardon?
It's 10 cm, quite big relative to the
You said
breast.
clinical.
Clinical, yeah.
And then you can have a 10 cm. That's when you look at it with regards to the breast, you can still go ahead and do the surgery for the person. Okay? So the fact that it's 10 cm doesn't automatically mean that the patient needs. So T4B doesn't automatically mean getting neoadjuvant chemotherapy. We have a lot of constraints, so those pushes us to do some of these things. But it's triple negative, so I agree. We can go ahead and do the neoadjuvant chemotherapy with adriamycin, cyclophosphamide, 4 cycles. But every cycle, the patient should be assessed. Every cycle of the treatment, every cycle, the patient should be assessed clinically, followed by paclitaxel times 4 as well. Every session that the patient is coming. Both teams need to assess the patient because we need to know whether the patient is responding so that if the patient is having a good response, fantastic, we go ahead. But if there is poor response to it, patients progress on chemotherapy. Yeah, so that we can intervene quickly and then change as soon as possible or suggest surgery for the patient. So we agree with your plan.
Then to
Yeah. It's an N2 disease. The other thing is with the mammogram, okay, usually clinical, we've come to realize, remember we're thinking of doing a paper on that, about the pull the range subjectivity amongst clinicians. And therefore, in some instances, actually the radiologists are able to tell us if there's an infiltration of the skin, especially when the lesion is so small on mammogram. Because clinically, you'll be palpating soft tissue above and around it. That will give you a large tumor, but mammographically, it will be very small. Okay? So some of those details can be provided on the mammogram to help us.
All right. So the second case is a under breast case, CM. All right, she's a female, 58, ECOG 1. Clinical, it's a metastatic disease. Clinical stage C, T4B, N2A, M1. Triple negative. She's premenopausal. No, she's postmenopausal, sorry. So HER2 positive. HER2 positive, sorry. Ki67, 40%. She's postmenopausal. I did a slide in a rush. There's metastasis to the T3, T4, and L1.
Is it lytic lesions?
Lytic.
That's an emergency.
The lytic lesions. So the context is this. She had a left mastectomy done some years ago in 2019. They didn't follow up with chemotherapy. Then she comes back with another breast TA on the right side.
So we are seeing the restaging in real life now. But then because it's lytic lesion to the spine, it's an emergency. So we start the patient on steroids and refer the patient for emergency radiotherapy.
Okay.
Okay. So by next week, the patient should be in Accra, but start the patient on steroids with some PPIs.
Okay. All right. The third case is an update. Next up.
So you can do 8 milligram BD for 3 days, then you do 4 milligram BD for 3 days, then 2 milligram BD for another 2 days, 3 days, I mean. So that's a total of 9 days of steroids. And then the PPI, 40 milligram of omeprazole.
Okay, thank you.
All right. The last case is an update. Patient was presented here, FZ 79. He had a right breast CA. Upfront surgery was suggested. We did the upfront surgery. Then the histopath following the surgery. The margins were not involved, but all lymph nodes were involved. The pathological stage PT1 and 3. There's no distance met. Yes, triple negative.
So you see what I was talking about with the tumor size? Yeah, from T4B to T1.
Yeah.
But then it's an N3 disease.
There was no neoadjuvant.
There's no neoadjuvant.
Drastically changed.
So you remember what I was talking about with the subjectivity with Boulderange?
I think we should be picking up the demographic dimensions as well. Because when it comes to Podo Ranch, there's a lot of.
Okay, so according to the report, the gross size of the tumor in the breast is 2 by 1 cm, and the microscopic size too is 2 by 1 cm, and that corresponds to a PT1 tumor. In the absence of tumor emboli within the dermal lymphatics, we cannot corroborate that to the clinical T4B, so it will downstage to PT1. Yeah, so that's their clinical assessment. Yeah. So maybe what I would suggest is if you have a case that you suspect is Podurange or clinical T4B, maybe during your biopsy, your core biopsies, you can also do an incision of the skin so that we will be able to see if there are dermal lymphatics to corroborate your Podurange. Because it's not always that you would have the dimpling appearance of the skin, meaning that there is tumor emboli within the lymphatics. You get what I'm trying to say? And also, I don't know who examined the patient, so that too counts. So the expertise of the one who is concluding that it is Podurange. Yeah. So you can even have normal breast appearing with Podurange, which may not really be Podurange. Yeah. So.
The other thing this case brings up is documentation. You said we discussed it at MDT earlier. Just think about it. Usually for a T4B disease, N positive, would usually want to downstage to improve cosmetic outcome. So why would MDT decide upfront surgery if there wasn't something that went into the discussion? So it's about information. Now you're updating us, but you didn't give us the reasons for our decision then. That's one of the things MDT needs. Okay? We are not coming after you. It's just, okay. Exactly. Okay, now it's not that you are offering that information, that it was because of her age and we're worried about side effects with her age and all that. But we didn't have that then. Okay, So now, with this new information, well, she needs further treatment. But I would also want us to hear from our radiologist about the imaging. We're talking about mammographic sizes and all that with respect to some of these things. We're still having some issues with, we are still getting reports where mammographic size is not stated and whether there's infiltration of the skin and all that.
The issue with measuring the mammographic sizes is the fact that most of times you are giving the films. Because if you want to measure, you must go to the mammogram room and use the calipers on the machine to do that, because the calibration is different from the normal ruler. So if you use the normal ruler, you underestimate or overestimate the size. So because we get the hard copies, and so far nobody has actually told me that they need the size from the mammogram. So I just report it as just a mass like that.
So please, we are telling you, we need a size.
When the machine starts working,
So radiology, adopt synoptic reporting.
In fact,
also, what happens most when we do the mammogram, we just go straight ahead and do an ultrasound. So we have a complementary ultrasound, and in the ultrasound we state the size. But if someone is doing just remote reporting, when you are just giving the mammogram, then you may not have the size until you tell the radiographer to put the calipers on it for you, so that when they print the images out, you have the calipers stating the sizes.
So today we are suggesting that all your breast lump that come for mammogram, please measure and then try as much as possible to tell us skin involvement and all that. And a complementary ultrasound will be appreciated.
3 years ago, we were trying to do some studies in that direction. Unfortunately, we didn't get funds. So if we had gotten funds, we would have resolved this kind of discussions 3 years back.
ENT. So if we are clear about how to demonstrate.
Oncology unit. She She needs some form of systemic therapy because it's triple negative. We are going to do chemotherapy. So she's 79, I think. So we'll have to do the geriatric assessment for her and assess her risks when we give her chemotherapy. What are the risks for like the side effects? How bad is it going to be? And based on that, we'll proceed with the chemotherapy with caution. So refer to us. And then we would also refer for radiotherapy as well. We probably will let her go for radiotherapy. She was HER2 enriched. Well, she still needs, so that's systemic therapy anyway, so let her come. And we will do it, we'll do the Herceptin with chemotherapy. Bah. No.
He said was positive. The updated one.
No. There was a different patient that had positive. Yes, there was a different patient that was HER2 enriched, but I think the 79 is triple negative. Yeah. But regardless, whether she even needed trastuzumab, we still needed to add chemo to it. So she has to come, we'll do assessment, and then we'll proceed with the systemic therapy and then the radiation therapy for her.
Okay, I'm Daniel Clote, ENT resident. We'll be presenting 2 cases. So the first case is Mr. E, 44 years old. The diagnosis of laryngeal squamous cell carcinoma, stage T3, N0, M0. So he presented with hotness of 1 year, 3 months, and then difficulty breathing of 2 months duration. We first saw him last August with hoarseness, which was progressive, unremitting. Flexible laryngoscopy done showed a left glottic mass, then stage T1, M0, but he was lost to follow-up on account of financial constraints and came in last 2 weeks in Stridor. We did an emergency tracheostomy for him. Following that, we did a direct laryngoscopy and biopsy. For the neck, there were no palpable leg nodes. Laryngeal crepitus was present. Otoscopy, rhinoscopy, and then oropharyngeal examination were all normal. The direct laryngoscopy revealed an exophytic mass on the left vocal cord extending to the anterior commissure with a narrow glottic inlet. All other laryngeal subsites were normal. Histology showed a well-differentiated invasive small cell carcinoma. And then the imaging showed a left transglottic mass with a narrow glottic inlet. And then there were no significant lymph nodes seen. So which stage is disease T3, N0, M0? ECOG 0.
So first, you have a tricky
We
institute.
did it last 2 weeks in Stridor.
Well, it doesn't matter. It's still a valid question. So that's the first question that will go to our ENT surgeons is, can we preserve the voice or not? It's an MDT.
We can. But it's a bulky T3. But long term, it won't help.
The patient has a tricky.
He has a trachea. Okay. He has a trachea, so it will be impossible. Yeah.
So, okay, so we can't preserve the voice.
No.
Then for total laryngectomy, you said there were
No lymph nodes.
no lymph nodes, not even suspicious.
No palpable lymph nodes clinically.
Yes.
Radiologically to know.
I will still want you to do a selective neck dissection.
Okay.
It was transglottic, so there's still a risk of level 2
All right.
for involvement. Okay. Based on the histological findings after surgery, we'll decide whether there's a need for adjuvant or not. Okay, adjuvant radiation or concurrent.
What's your patient's profession?
He's a carpenter.
He's a carpenter.
Is he boarded? No, you need to talk to him
Yeah.
before you go ahead and do the surgery.
And
Because that's going to change his quality of
Yes.
life, so you need to talk to him. Do we have a clinical psychologist?
and can you do a new?
Is there a clinical psychologist in the house?
Can you put in that?
They are where?
The voice prosthesis. Yeah, we can put in the voice prosthesis.
Oh, we can put in a
Yeah.
voice
What are they
prosthesis.
doing there?
The voice prosthesis.
Oh, okay.
So for total laryngectomy with voice prosthesis,
Yes.
then we'll take it from
All
there.
Mm. And the next case is 70 years old Mr. IA. Also diagnosis of laryngeal squamous cell carcinoma, stage 3 M0. 1 year history of hoarseness, and then a month ago, difficulty breathing, for which we presented to a peripheral facility. They nebulized and referred him here. So we did a tracheostomy for him 2 weeks ago. In fact, the same day as the first patient. So following the emergency tracheostomy, we did a direct laryngoscopy and biopsy, which showed a bulk esophageal mass, bled easily on contact. It extends from the right false cord through cord, and they involves the anterior commission on the contralateral side. The esophagoscopy was normal. Histology was a moderately differentiated squamous cell carcinoma. Yeah. And then the imaging showed a right transglottic mass with involvement of the anterior commission on the left. Also, clinically, we didn't palpate the thyroid gland, but radiologically, we noted that the contralateral, that's the right thyroid gland, was enlarged with some mediastinal extension, measured 7.2 by 3.4, extending to the superior mediastinum. There are no palpable lymph nodes. We stage this laryngeal disease T3 M0, ECOG 0.
Just a quick observation. The images, were they contrast enhanced?
So this is image.
I was just wondering, because the ones you projected, yeah, this is the one I took from. Yeah. I'm just wondering, were they contrast enhanced images?
It looks like, yeah. Yeah, it looks like.
Okay, I can see that over there. All right, so same question as before.
We can't preserve the voice.
Then a similar thing like the first patient.
Yes.
Total laryngectomy. I don't know whether the team would want to do a thyroidectomy as well. That's surgeon's discretion.
When you're doing the laryngectomy, you take out the ipsilateral thyroid.
Okay.
Yeah. So this thyroid is on the contralateral side. So it will depend on the surgeon. Dr. Video has to see.
Okay. All right.
Dr. Video. No.
After surgery, what else?
After surgery is based on the pathology reports. It's not all T3s that would require adjuvant radiation therapy. Okay. So it's based on the path reports.
Okay. Any questions? If not, we'll go to the last presentation. Hey, are you done? You may come. Oh, if you're not presenting, let me know. Come, we're waiting for you. I'll present the second one.
No, like the CT scan and the rest. Okay, so the first case is a Resi. So she's a 46-year-old female. clinical stage, histology, NST, invasive carcinoma, NST, histology grade 2. Clinical staging is C. What? So as I said, 46-year-old female, histology, invasive carcinoma, NST, histology grade 2. Immunohistochemistry, ER positive, PR positive, HER2 negative. Tumor stage is T4C, N1, Curie M. So the lymph node, the axillary lymph node that were palpable. We are Curie M because the CT scan gave us an impression of a focal enhancing lesion, which is about 1.2 cm in the hepatic segment 8. Differential diagnosis of hemangioma or METs. But when she did a mammogram, they were highly suspicious for malignancy grade 5, speculative lesion at 1 o'clock, which is about 3 cm from the nipple of the left breast. And they were also suspicious lymphadenopathy present as well.
Can we have a comment from radiologists? The
suspicious lesion in the liver.
As I said, when it comes to hemangiomas, the way they appear. Okay, I think first of all, the main thing was the image an optimized image? It was an optimum one, but there are some glitches in the phases in which the enhancement and images were taken. That means that you can't really boldly pick one of them as your differential, as your diagnosis. Because if the hemangiomas, they tend to enhance in the arterial phase. If it is small, you have to use homogeneous enhancement, and that'll be all. But if it's a bit larger, they tend to have nodular peripheral enhancement. And as the lesion progresses in the later phase, like portal venous phase, they tend to increase in the enhancement pattern. Then the delayed phase, they are still bright. But when it comes to MET may have just peripheral enhancement. And in the portovenous phase, it will not fill in. So it will maintain that image. Or in the portovenous phase, if it doesn't fill in, there will be washout. And that washout will persist until the delayed phase. So I don't know how it's appeared on the imaging. Maybe they missed the portovenous phase and went straight to the delayed phase, or the arterial phase was the early portovenous phase that was taken as arterial phase. When it happens like that, you are in the dilemma to choose one. I mean, not because hemangiomas are the most common benign hepatic lesions, then maybe you pick that one and add MES because of the history of a breast cancer.
So, was the imaging done in CCT?
Yes.
So can we have radiology review? Dr. Ntivu, can you review the images for us?
Is it my name that is on it? Then Agala will have to review. No, that's how it is. So that another person will review. Because maybe because of what I saw, I couldn't stick my head out and pick one.
Okay.
Yes.
Yeah. Okay. Thank you. So we'll have radiology review it because it will change our management plan significantly. So whilst radiology is reviewing, we'll also start work here up in the clinic whilst radiology reviews the image for us. And also send a comment. You can liaise with Dr. Nti and then she'll have a chat with radiology and then we'll take it from there. Thanks. If it's not metastatic, we are going to do neoadjuvant chemotherapy. She's luminal B, HER2 negative luminal B. We'll do neoadjuvant chemo with AC4 followed by paclitaxel 4 cycles to get the best clinical outcome. Okay, she's a T4C.
Yes.
And then this will be followed by mastectomy, but we'll be reassessing after every cycle, both oncology and surgery.
Sorry, just a little to add on. So on the examination, there was podorange, there was dimpling, nipple retraction, but there was also attachment to the skin and also to the pectoralis major muscle as it is indicated in the.
Thank you. So we'll try to get the best outcome with neoadjuvant. So these are the kind of patients that we would want to do everything. If they are responding, we would want to finish the full neoadjuvant treatment before they go in. But then the reviews must be done by both the surgeons and the oncology team, okay? Because there's a risk. If the patient, maybe after the first anthracycline-based chemotherapy, becomes operable, but we want to get more response and we are continuing, and during the taxane phase, after the first cycle, we notice that maybe the patient is progressing, but it's operable, we'd want you to go in quickly. That's how come both teams must follow up with the reviews after at least every cycle, to examine at least. Yeah.
I think there was a patient that was receiving chemo, and then while she was receiving, we noticed that the lesion in the axilla had responded, but the central one was progressing. Surgeon says it's operable. We went ahead and did the surgery. We didn't even bother with the second round of chemo.
Okay, so this particular case was presented earlier. So he's a 67-year-old male. Histology diagnosing intermediate neoplasm spindle cell tumor with areas of necrosis at the left upper part of the chest. Immunohistochemistry, Ki67 less than 5%, STAR6 was negative, no nuclear cytoplasmic staining, CD34 positive, variability positive, the breast. So tumor, spindle cell tumor of low grade, lymph nodes were not palpable. So this particular patient had a wide local excision on account of dermatofibrosarcoma protuberance of the left breast 4 years ago. And he did a chest CT scan recently, which says suggestive of a malignant left apical tumor with adjacent ribs invasion, extrathoracic extension into the left axilla, and a mass defect. So he went ahead to do an image-guided biopsy of the chest, and there was intermediate neoplasm, spindle cell tumor with areas of necrosis. Diagnosis, spindle cell tumor of low grade.
This is interesting. So we'll have the pathologist. We'll have the pathologist review it.
Yeah, so from the IHC, so STAT6 is negative. So usually STAT6 is useful when you want to confirm a diagnosis of a solitary fibrous tumor, which is sort of a benign lesion, but can be locally aggressive. Then CD34, most of the time, would be when you are trying to discriminate between dermatofibrosarcoma protuberance and maybe a dermatofibroma or some other spindle cell morphology. So for this case, we will have to review the morphology again and see if we can suggest more IACs to help come to a conclusion. So that can be done, and after that we would see what stains would be positive, then we can further type the lesion so that the patients may benefit from the appropriate treatment available. Yeah. So do you have a copy of the report?
Actually, it's not here. For his, it's not here. Those are the hospital.
No problem. So we can have a look at that.
This particular patient came last week to the ER with difficulty breathing and easy fatigue, and he's not really able to talk loud. No, not recently. Yes, it was done, I think, about 2 months ago.
You have to repeat. I've seen somebody who has progressed within a week.
It's behaving like a sarcoma.
But she's had surgery before.
Yes, 4 years. Why local excision?
She had surgery for DF.
4 years ago.
The same breast.
Yes, the same site. So he came back with easy, yes, he came with easy fatigue.
So it can transform into a fibrosarcoma, or it may be a recurrence of the DFSP, or it may be a new tumor which is forming. You understand? So, as I said, we have to review the case to see. Not too sure of what was seen morphologically. Yeah.
So actually, when he came with easy fatigue and difficulty breathing. That's how come he went to do image-guided biopsy of that particular site. We said intermediate neoplasm, spindle cell tumor with areas of necrosis. So, left apical tumor, adjacent rib invasion.
Extrathoracic extension into
Yeah,
the
so-
left axilla. So where is the lesion located?
On the left breast.
Where? Where in the left breast?
This side.
Like, so do you get where I'm
Yeah,
coming
like
from?
where exactly?
In the left breast. Which of the quadrants?
Is a
CT, it looks like the lesion is at the apical lung and it's having extra thoracic extension into the axilla.
He has it all the way here.
From the
Yes, I had a
yes,
picture.
I agree with you. So that's why I'm asking where exactly is the lesion located?
So it's actually all around this side. I wish
So
I had a
it's filling the
picture
whole
of it.
breast?
Yes, this side. I wish I
So
had a picture of it.
I think this patient will need to be seen by both oncology and then the surgeons, where we all stand there and examine together and then make our decision based on the clinical examination, radiological examination. Then we'll have pathology also review the slides for us, and then we can come to a conclusion with it. The problem with low-grade sarcomas is that they are worse than anything you can imagine. But it's low grade. Low grade doesn't respond to anything. Surgery is the way to go. Low grade will not respond to chemo, will not respond to radiation. So we need to be very sure what we are dealing with, and hopefully it will be an intermediate one. I agree with you.
No, we have a third one.
It may be that the area of the tumor that you have biopsy is showing these low-grade features. But in other areas of the tumor, maybe...
It's different.
I agree. You get what I'm trying to say? So because of the concept of heterogeneity within the tumor, it may appear as such. So most of the time, what we will suggest is if it is a tumor which you can resect with like good margins, then we can now examine the whole lesion. No, I'm just saying, yeah. But if it is a situation that you cannot resect, then what we can do is the further testing with other IHC markers to try and come to a conclusion. Yeah.
Over here.
All of it.
Yes. Even the one local excision was done here 4 years ago. Copy of it. He has to repeat the chest CT because the films are actually old. It's like something has poured and they are stuck together. So I'll write.
It's not the histopathology. The histopathology.
Yes. He has to repeat.
They can get it for you.
No, everything from 2004 to 2002,
I
2003
don't have that one.
has
I'll
been
have
cleared
to
from
ask
the system
patient
because
if
our
he
way
left
was
it,
full.
because that was
We don't have a
4
PAC
years
system
ago.
yet. So this, you only have 2025 CT scan.
Sorry? Yeah, but
It was done 2 months ago. Then.
roughly 2 months.
The last case. We have to-
Yes. So it's a 59-year-old female with histology diagnosis invasive carcinoma with mucinous areas. Tumor is at the transverse colon carcinoma with hepatic mets. So she presented with abdominal distension of 3-month duration. She's a non-hypertensive and diabetic, and she was being managed by the internal medicine on account of bilateral DVT of the lower limb, bilateral pulmonary embolism, and she complained of abdominal pain at their end, and they made her do a CT scan and ultrasound-guided core biopsy. So ultrasound-guided core biopsy came out invasive carcinoma with mucinous areas, histology grade, low grade, and CT scan of the abdomen and pelvis, a circumferential bowel wall taken involving the hepatic flexure and proximal transverse colon, suggestive of colonic carcinoma with proximal small bowel dilatation, small size mesenteric lymphadenopathy with hepatic mets and moderate ascites.
So multiple hepatic lesions, right?
Yes.
Is he obstructed? Right, well, you can still go in and take out the primary lesion, and if possible, refer for palliative systemic therapy, chemotherapy afterwards. Okay, so you can do your hemicolected, extended hemicolectomy, and then refer to us. Okay.
Thank you.
Good afternoon. My name is Dr. Grant. I'll be presenting on behalf of Prof. Mona, OTMS. I have one case. So we are, Madam HY, she's 48 years. She's basically a CT 4B N2A M0, ER positive, PR negative, HER2. Please. Hi. So basically, this is CT4B N2A M0, ER positive, PR negative, HER2 negative, KI 67 of 70%. Unfortunately, her metastatic workup was by chest X-ray and abdominal ultrasound, but they were, however, negative. So we are thinking of doing a neoadjuvant chemotherapy. The tumor size is actually quite large compared to the breast. So we are thinking of doing a neoadjuvant chemotherapy and then modified radical mastectomy with adjuvant radiotherapy. And then adjuvant hormonal therapy as well. She's premenopausal. 48. I'll have to ask. 48.
So we'll do, she's luminal B, locally advanced. We'll do a neoadjuvant chemo with AC4 Taxol 4 cycles, and then we'll go in. Afterwards, adjuvant radiation and hormonal therapy.
Thank you.
Please, did you get that? Okay. Thank you very much. Our lunch actually has been waiting for a long time. But before we go for the lunch, we'll need to take one picture for our sponsors. So if we can all come in front and take the picture before we go for the lunch. We'll come back for the final feedback and everything. So please let's hurry up and we'll do it in front here. Can we quickly come in front and take the picture? Hey, where is the guy?
We have paid for it. Thank you.
let's kindly make our way to the. So, put the post. Please, let's go to the. The lunch is at the restaurant. Please, let's quickly go there and have our lunch. Is that okay?